forward it to the technical committee.
Shall we start?
Yeah, I think we can start. Yeah.
Yes, sir has joined.
Yeah,
Yes.
you can.
Yeah, Dr. Arundhara has also joined. Yeah. Welcome, sir.
Good evening, everyone. I, Dr. Divya Khosla, on the behalf of organizing committee, welcome you all to day 2 of Indian GI Cancer Congress Chapter 1. And for the quite eventful and fruitful day 1 of this event, I would like to thank all the faculty, experts, speakers, participants, and the members of our organizing team. Today, we'll be discussing various aspects about the management of carcinoma esophagus. And running similar to yesterday's pattern, today we also have some case presentations pertaining to real life case scenarios, which we all face in our day-to-day practice. Today, in addition to the eminent national faculty and speakers, we have 3 international speakers of great repute. Dr. Somnath Mukherjee, Dr. Edgar Ben Joseph, Dr. Pablo Munoz, who not only will throw light on various management issues, but will also share their experience in treating this malignancy, and which will surely steer the discussions to a new level. We all know that active participation and two-way dissemination of knowledge is the best way of learning new things. This is what we saw yesterday, where we had good, fruitful discussions, and we saw so much enthusiasm and intensity in discussions. So today, again, it's my humble request on the behalf of organizing committee to all the participants to please feel free to circulate and circumvent your views and queries in the chat box. And we'll also be discussing online survey results pertaining to carcinoma esophagus at the end of the session. So without wasting any further time, I would request our esteemed chairpersons, Dr. Rajesh Vishish sir, who is President EROI, Associate Director, Department of Radiation Oncology, and Medical Advisor, Max Super Specialty Hospital, Bathinda. Sir does not need any introduction. He's a wonderful human being, and he's doing fantastic job in shaping the future of many young fellows. He's a known face in the list of invited faculty in various national and international conferences. Thank you very much, sir, for agreeing to be part of this conference. And our next chairperson is Dr. Rakesh Kapoor. Sir is Director, TMH Sangrur and Mullapur, Punjab. Sir is also President, Norson EROI. I have an additional edge as Dr. Rakesh Kapoor is my teacher, and I have the pleasure of working with him at PGI Chandigarh since my residency days. Dr. Kapoor, as we all know, is having expertise of more than 20 years in managing GI malignancies, and he has more than 150 publications to his credit. His oratory skills are beyond excellence. We welcome you, sir. And our next chairperson is Dr. Tapan Saikia, sir, is Head Medical Oncology and Research Director, Prince Ali Khan Hospital, Mumbai. He has numerous publications to his credit and is a very renowned medical oncologist. Thank you very much, sir, for agreeing to be part of this conference. Handed over to respected chairpersons for starting the program. Thank you.
Thank you, Dr. Divya, for nice words and appreciation. And thanks for the organizing committee of Indian GI Cancers, that they have all updated us in the difficult periods of time. I think everybody get benefited by these conferences. Thank you for organizers. Now, I invite Dr. Kinjal Jani. He also need not any introduction. He is the Gujarat Cancer President of Gujarat Cancer Society, also ARI chapter of Gujarat Cancer, and he at present Director and Head of the Radiation Oncology SCG Cancer Center, Ahmedabad. And he has so many numerous publications and presentation in international conferences also. So Dr. Kanjali will moderate in the management of cancer esophagus. In turn, as the results are improving in the esophagus, we need update on this. Dr. Kinjagali, over to you. Invite your next panelist.
Thank you so much, sir, for the kind introduction. And it is always pleasure to have you to introduce me, because we have been very close, and all of us know that. And thank you so much for the introduction. As Dr. Divya rightly mentioned that we had a fruitful day discussion yesterday, We had a very good discussion on CA stomach, and today, we are going to continue on the CA esophagus. And the purpose of this meeting was to, talk about the places where, we have a dilemma, what to do and what not to do. So we have designed this conference in such a way that we will have a panel discussion where we discuss a particular case, and then we'll be having a talks from the experts that, what is the evidence of managing those cases. So today I'm going to discuss a case on CA esophagus, and I'd like to invite my panelists. So my panelists are Dr. Anil Tiblewal. He's a surgical oncologist and a well-known person.
No, I'm not a surgical oncologist. Please correct that. I'm a radiation oncologist at Tata Hospital, Mumbai.
So I'm extremely sorry, because what I got was a surgical oncologist. I'm extremely sorry for that. Then we have Dr. Arun Goel. He's a senior surgical oncologist. We have Dr. Pooja Nandwani Patel. She is a radiation oncologist in Ahmedabad. Dr. Hemendra Mode is a radiation oncologist in Rajkot. Dr. Joydeep Ghosh is a medical oncologist. I am not very sure whether he's joining or not, but anybody can correct me if he's joined or not. And
He
Dr.
is not
SP
joined.
He's joined?
No, he is not, sir.
Okay, so he's not joining. So we have Dr. SP Srivastav. He's a close friend of mine who was practicing as a radiation oncologist since last 15 years. And right now he is doing a residency in medical oncology. So I have named him as a clinical oncologist because he was a radiation oncologist and now practicing medical oncology. So I'll request all my panelists to switch on their cameras and turn on the mics so we can have a fruitful discussion. I'll try to be as brief as possible because we don't want to waste time on the talks. So I'll ask a very brisk, very up to the point questions. So about the case what we are discussing today, this is again a case which we had given an answer during the registration. So this was a case of a 75-year-old male having dysphagia to solids for 2 to 3 weeks. So he was worried that he's having a dysphagia. He has an ECOG 0 and a 70 kg weight. So he's a well-built guy at the age of 75 and has no comorbidities. But he has a past history of CA tonsil 6 years back, for which he was treated with radical radiotherapy around 70 gray with a weekly cisplatin, and he was cured from that. So when he started having a dysphagia to solids, he thought, let me go to my radiation oncologist and a medical oncologist who cured me from my malignancy. So he was thinking that he has some problem in the esophagus. So he went to the radiation oncologist who guided the patient to a GI physician, and an upper GI scopy was done, which showed that there was a growth in the lower third esophagus, starting from the level of 34 centimeter up to 38 centimeter, around 4 centimeter in size, and the GE junction was at the level of 39, and which was not involved. So it was a lower third esophagus growth around 4 centimeter in size on the scopy, and the biopsy came out to be moderately differentiated squamous cell carcinoma. So now this patient came back to the radiation oncologist. So first I'll go to Dr. Anil Tiblewal. So you are the guy who treated him with radical RT and CT for CA tonsil. So he's coming to you and comes with a report of the upper GI scopy. So what would you do, Dr. Anil?
Yeah, so first of all, I think he's an elderly gentleman with a very good performance status of ECOG 0, and he has a recent onset dysphagia to solids, so grade 1/grade 2 dysphagia, and obviously he has been treated for CA tonsil. So my first investigation would be to do a PET CT scan to just rule out the distant metastasis as well as the regional lymph node or non-regional lymph node.
Yeah.
Should I read that?
Yeah, so I absolutely agree with you because this patient comes with a dysphagia and has a lower esophageal growth. We would be worried about the primary site also. So you would get a PET CT scan done, and this patient also underwent a PET CT scan, which showed a 3.2 centimeter segment of lower esophagus showing a growth with a high SUV uptake. PET planes with the descending aorta and the pericardium were preserved, and there were no nodes showing any uptake. But there was a small subcarinal lymph node positive, which was on a CT but not on a PET. There was a small node. The tonsil and the oropharynx, which we are already worried about because he was a patient of CA tonsil, was appeared to be normal, and there was no other uptake in the body. So now I ask another question. If this was a patient treated by Dr. Pooja Nandwani, that if this patient was treated by you for CA tonsil, and this patient comes to you with this kind of a report, would you investigate this patient further, Dr. Pooja?
So I think it looks to be a localized disease, but I would like to confirm it within EUS so that we are very sure that's a very localized disease only. because the US will be really helpful for us to differentiate it from an advanced disease T3, T4. Also, any lymphadenopathy which could have been missed could also be taken up by the US. So I think any US would complete the picture before we can decide what should be the treatment of choice for this young man.
Yeah, so I take it from you. I'll go to my surgical oncology colleague, Dr. Arun Goel, sir. What would you want to investigate? Would you go for an US, Dr. Arun Goel, sir?
I personally may not need to go ahead with the US. I had seen the PET CT pictures which were shared in the presentation which was given before. So seeing the extent of tumor on endoscopy, which is 4 centimeters, on PET CT, which is 3.2 centimeters, and in terms of the thickness of tumor also on PET CT, it seems to be quite a bulky tumor. So my primary approach for this patient would not be upfront surgery. So from that point of view, for me, a US will not make a difference to the decision making.
Okay. So, rightly said by sir that, a PET picture would also make it very clear to you. So I'll just share the PET picture which sir has already seen. And you can see here that, you can see it's a very small lesion in the lower esophagus. You can see it very nicely here. It's a lesion in the lower esophagus. Again, you can confirm it with the sagittal cuts. You can see there is a lesion in the esophagus. But one of our panelists wanted to do an EUS, and the EUS finding was also showing a small lesion around 2 by 1.5 centimeter mass in the lower esophagus, which was breaking through the muscularis propria, but not involving the adjacent structures. And again, there was a small subcarinal node in the EUS. So we are dealing with a disease which may be around T3 disease, as rightly said by Dr. Arun Goel, sir, that it looks like a T3 disease. A node, you can say N1, N0, it's a doubtful thing. So this is a scenario which is there in front of you for all the panelists. And now comes the question, because our main discussion today is how are we going to manage this patient. So Dr. Arun Goel, sir, has already given his opinion about the surgery, that he would not be very keen to go for upfront surgery. But let me ask my other panelists. I'll go to Dr. SP Srivastav, if he can comment whether he would go for an upfront surgery or not. Though he being a medical and a radiation oncologist, what is his take on this? Dr. SP. SP is there? Or Dr. Hemendra can take it. Dr. Hemendra.
Yeah, I would agree with the remaining panelists that upward surgery is not an answer for this patient, right?
Yeah, so you would also not think about the upfront surgery for this patient.
No,
Dr. Anil, Dr. Pooja, you want to make a comment?
No, so I am very happy that even if my surgeon is agreeing that he would not like to be the first person to start the treatment, then I think with the tumor board discussion would be very clear that we would go for a pre-op CTRT followed by surgical approach.
So I agree with Dr. Pooja that upfront neoadjuvant CTRT could be an option. However, I would like to ask why we have not done the subcranial node FNAC from the EUS if we are not sure about the N0 or N1. It could have been done at the same time, because whatever it's said and done, the EUS is still saying that it is not involving the adventitia, so it's not T3. However, radiologically it looks like a T3, but still we are not very sure.
So I'll make it a bit clear to you. Biopsy was done, say EUS and a biopsy was done from the subcarinal node and it was negative. So
Okay.
now you're dealing with a T2, T3 disease. You may take it as a T2, you can take it as a T3, and you give your two opinions. What would you do if it's a T2? What would you do if it's a T3? Dr. Anil.
So if I'm right correctly, the biopsy from the primary is a moderately differentiated squamous cell carcinoma and not the well differentiated. If it would have been a well differentiated T2 the tumor, we might have gone ahead with the surgery also upfront. But however, it depends upon the operating surgeon how much comfortable he or she is. Right now, in this particular case, we could go ahead with the neoadjuvant chemoradiation therapy to a dose of 41.4 gray in 23 fraction.
Yeah, Dr. Arun, would you want to make a comment on this?
Yeah, definitely. I want to make a comment. See,
yes.
There are two things. Say, technically, I can go ahead and operate this patient. The issue is not that the patient is not technically inoperable. Technically, I can go ahead and operate. But the question is, let us say that we have some debate about one, it could be a bulky T2 or a sort of early T3. The size which EUS says 2.1 or so, I would say the size in terms of the length will not be picked well on EUS. So we have to have the endoscopic size, we have to have the PET size. So we cannot say that the size is less than 3 centimeters. Size is actually lengthwise more than 3 centimeters. Diameter wise, it is less than 3. So I would take it as a slightly bulky T2 at least. And as I said, squamous cell carcinoma is a situation where neoadjuvant therapy works well. And after surgery, there is no opportunity to really benefit the patient with additional therapy. So in spite of being technically operable, I would want to give this patient the benefit of neoadjuvant therapy. The questions which could arise are whether we are going to go with concomitant CT, RT or RT alone in view of his age. So that can be an issue to be discussed.
Yeah, so that is exactly what I wanted to discuss with all my panelists. And all of you are on the same grounds that all of you would go for some form of neoadjuvant chemotherapy, radiotherapy combination before you go for a surgery. So I'm not going to discuss more about the NSCRT part, but now comes the question. If you talk about a medical oncologist, what would his choice of drug be? Whether they'll go for a paclicarbo or a cisplatin plus 5-FU. So any of my panelists who is using a concomitant chemotherapy along with the radiation can take this question. What would be your choice of drug be? Anybody can take it.
So, Kinjalbhai, like in this particular case, when I think the set was very much the stage was set by you to confuse us all, but I think we were all on the same grounds, the surgical oncologist and Dr. Anil and us and Dr. Hemendra Bhai, that yes, we all would like to go for the pre-op CTRT, and having decided that if the patient is in good general condition and if there is no other problem, then I think we would go with the standard cross protocol, giving a paclicarbo plus 41.4 gray. That would be the standard way to approach. But however, I would like to discuss with the medical oncologist also if he would have some different opinion from me.
Yeah, so before we started with the cross therapy, before we started with cross, people were using cisplatin plus 5-FU, and that was also showing a good result. But after the cross trial, we have been all moved to paclicarbo and moved away from cisplatin 5-FU. Unfortunately, our medical oncologist Dr. Joydeep has not joined, and I think SP is also not there. So we have not much of a debate on this. So let me just go forward. But this patient was treated with concurrent CTRT for CA tonsil, and he is so happy with CTRT. He is saying that I don't want to see my surgeon. I am happy with my radiation oncologist and my surgical oncologist. So any of my radiation oncologists, I'll go to Hemendra board first. Will you be keen to go for a radical RT with cisplatin for this patient? It's a very small lesion. It's a very small lesion. It may be T2, it may be T3. You can go for a radical RT with cisplatin. Will you be tempted to do that, Dr. Hemendra?
See, as you said, if the patient is not willing for a surgical option, right, then yes, of course, radical RT. But I would be more comfortable using radical RT with paclicarbo rather than with cisplatin. I've seen much less toxicities along with paclicarbo rather than cisplatin.
What would your dose be? 50.4 or 54?
50.4.
Okay, and how about 60? Because if we talk about 10 years back, we used to give 60 gray before 10 years. Right. So, so when you and I did my residency, we used to give 60 gray for esophagus. Yes. So, would you be tempted to go for a 60 gray with cisplatin, or maybe 50.4 or 54 with paclicarbo?
No, unless and until the cervical esophagus is involved, the dose escalation might
lower esophagus. So we know it's a lower esophagus.
So then there is no role of escalation of the dose. The 50.4 to 50 is more than enough for the radical RT.
Anybody going for a radical RT alone for a 54 gray? Dr. Anil, Dr. Pooja, either of you?
If I may come.
Yeah, please.
Yeah. So so we know that both of the randomized control trial, the Art Deco and the Chinese trial of the dose escalation has failed. However, we do still practice the 60 gray in 30 fraction for squamous cell carcinoma at Tata Memorial Hospital, because in our own analysis, so that Dr. Naveen has just sent for publication, we have found that the 60 gray was much more beneficial as far as the local progression-free survival as well as overall survival. However, the randomized evidence do not support that. We agree that, but as per our institutional practice, we do follow 60 gray. However, in this particular patient, we can opt for 50.4 gray in 28 fraction as is elderly, the low volume disease, T2/T3. So we can still wait. So we can still restrict us to 50.4 gray in 28 fraction.
Yeah, so I would agree with you, all of you, that we would be tempted not to go for a dose beyond. So I'll not be confusing you more, because we all agree that we'll not be going beyond 54, maybe 50.4 to 54 if no surgery, if surgery 41.4 to 45. So that's a clear in our mind, because the time is limited. I'm going to
Dr.
stop very
Kinjal,
fast. I'm going to stop
Dr.
in a minute's
Kinjal,
time.
Dr. Rakesh Kapoor sir wants to add something.
Yeah, please.
Now I'm in the other side, in the chairperson side, but I like to add one thing here. Once you do concurrent or the sequential chemoradiation, one must keep in mind that the dose of 50.4 gray, which you are saying, by adding chemotherapy, you are already increasing the BED by 4 to 5 grays. So actually, we are giving a dose of 54 to 55. So we need not to increase the dose to 54 to 60. Anil, what we do in Tata, that is once we are trying for 60, you must have seen in those patients, we are not going beyond 3 to 4 cycles. So it is always logical that once you do concurrent chemoradiation in esophagus, always try to do the total dose up to 50.4. Never exceed the dose. Also, the dose per fraction should be kept at 1.8 rather than 2 gray, because otherwise you will have a lot of toxicity and the patient will not be in a position to complete the treatment. And always remember, this protocol of concurrent chemo RT is going to increase the BED by 4 to 5 gray. So you are actually in the same range.
Yeah, so we agree with you, sir. You are right. You have rightly mentioned that we don't need to go for a 60 gray, which we were doing like 10, 15 years back. So nowadays we keep it for to 50.4, and very rarely we go up to 54 if there is no chemo involved. The last option was a palliative RT. I will just take 10 seconds if anybody wants to go for a palliative RT. Anybody? Pooja, Anil, Dr. Hemendra or Arun sir. Anybody would go for a palliative RT? I think nobody would. Anybody?
Dr. Kinjal,
No.
just one comment I would like to have.
Yes, sir.
This debate between neoadjuvant versus radical. So one of the situations I think all of us face is that a patient has been started on a neoadjuvant therapy, and
So that was my next question, sir. That was my next question coming to you and my radiation oncologist. So I'll just stop you here, and my last question will be to all of you. My last question to all of you. So we would agree that we will not be going for a palliative RT because this patient was a fit patient, ECOG 0, 70 kg weight, a 75-year-old guy wants to get cured. So nobody would go for a palliative RT. And now comes the question, because this question will be answered by the next talk by Dr. Somnath. He's going to talk about this, and he'll give you evidence that what happens if you start with a neoadjuvant chemoradiotherapy and patient has a complete response after neoadjuvant chemoradiotherapy, and what will you do? So that's a hot question comes, because an elderly patient who was cured with chemoradiation earlier is given a preoperative chemoradiation, is cured and does not want to go for a surgery. So what would you do? So I'll start with you, sir. Dr. Arun sir, what would you do?
See, definitely, if the patient has a complete response and is desirous not to go for surgery, I would respect patient wishes. The basic issue right now I have is about the dose of radiation.
40, that's what it's a 41.4 gray, sir. So it's a 41.4 gray. What would you do if it's a 41.4 gray?
No, I am not happy with 41.4. So there is a question of how to sort of supplement either the radiotherapy in terms of giving an additional dose. So that is
after a month, you waited for 1 month. You waited for a month to see the response before you operate, and you waited for a month. Would you be boosting it up, or you would just operate? What would you do?
No. I would like to operate. That is the standard of care. But if the patient for some reason is absolutely not willing for surgery at that stage, and if the choice is between sort of he defaults from treatment, or we can offer him some supplemental radiation. So that is the question at that time.
Okay, so a very quick response from Anil and Pooja.
I think Dr. Kinjal, we shall move on to the
last comment from them. Dr. Anil, Dr. Hemendra, and Dr. Pooja.
So
Sorry,
I
I
would
didn't get the question.
So, if the patient is given a preoperative chemoradiation, 41.4 gray with paclicarbo, 5 cycles, and now patient has a complete response after 1 month, and patient does not want to go for a surgery. What would you do?
See, according to the SANO guidelines, if the patient is not able or is not willing to go for surgery, then very strict surveillance strategy is there. So with a PET CT scan at every 6 weeks or 2 months, and a deep biopsy from the residual or the suspicious area, that we need to undergo for the patient every 8 weeks to 10 weeks. So this is the problem that we are going to face, because the pathology is a complete clinical response that I'm sure that Dr. Somnath Mukherjee is going to tell.
Yeah.
Uh, it's not the standard of care currently, but
Yeah. So quick comment for Pooja and Hemendra. Very quick comment. Very quick, please.
So my quick comment is that I try to be very quick to the patient in the first counseling only. That see,
Exactly.
this is a pre-operative dose. Please don't mix it. Even if you are seeing that you are you're responding well, that does not mean that you will be omitting the surgery, because that dose is just to decrease the tumor size or decrease the extent of the disease. But at this stage, when you're already past 4 to 6 weeks after the radiation, and then you are asking the patient gives the option that I don't want to go for surgery, it's a total mess, because you're nowhere left. You can't complete the radiation dose also, and then it's a complete mess. It's better that the counseling should be very important and very strictly done on day one, that you have to go for a pre-operative radiation chemo dose and then followed by surgery. And if last patient does not agree, then there's no option. Then of course, mess is a mess. Then neither you can add a boost also. That doesn't make much difference.
Exactly. I absolutely agree with you. The day one counseling is very important. I would tell my patient, if you're going for a pre-op RT, you have to get the surgery done, whatever the result of pre-op RT is. Hemendra, any comments from your side?
I totally agree with you. The counseling has to be important. Pre-op means pre-op. You have to somehow convince the patient to go in for surgery after the treatment is over.
Absolutely. So I'm very happy with my panelists, and they're all on the same grounds, and I'll stop it immediately because Divya is itching to stop me here. And Dr. Somnath is going to give you all the comments. So you all be online and just hear to what Dr. Somnath has to say on this. So thank you so much, all the panelists. It was a nice discussion. Thank you.
yes, thank you very much.
I thank you, Dr. Kinjal. I request Dr. Tapan Saikia to please invite the next speaker.
Thank you. Now I invite Professor Somnath Mukherjee from Oxford University, UK. I looked up at his CV in the Google in the morning, and he has been doing a significant amount of work in pancreatic cancer and esophageal cancer. And today he has been requested to talk on complete clinical response after upfront CTRT challenges and detection. Treating esophageal cancer has never been easy, and it's not going to be easy for years to come. Professor Mukherjee, please.
Right, okay, can you see the screen? Can you see my screen now?
Yes, we can see.
Thank you very much for the invite. I really enjoyed the initial discussion. And I have to say, I have got 2 or 3 comments about the initial discussion. So first of all, there seems to be a very strong, he's a 75-year-old guy with a relatively localized tumor. Certainly in the UK, if this patient went, and a squamous cell cancer, if the patient went across the UK, but there would be nearly a 50-50% split between whether he would have DCRT or NCRT. Half the units in the UK would not offer him surgery or would strongly offer DCRT as an option. Second, so that's one thing to bear in mind, that how the practice is strongly different between the 2 countries, because as we know, the randomized studies of DCRT versus NCRT does seem to indicate very similar outcomes. The other is, which I kind of share, was about between the, if you have given a neoadjuvant dose, then you're kind of doomed. And what happens if the patient says no? But if you look at the cross study, 50% of the patients, 49% of the patients with squamous cell cancer had a complete pathological response. Now, I don't know of other studies. If you look at studies which have used 50 gray, 60 gray, or whatever, I'm not aware of any study where the pathological response for squamous cell cancer has been shown to be higher than 50%. So if any of the panelists before can quote a study where the 41.4 has a lower response than the 50 or 60 gray, I'd be interested in that study. But certainly, you know, obviously, if the patient comes to me, yes, I wouldn't just go 51. So my preoperative dose anyway is 45 gray, just for that kind of a reason. Now I'm going to start with a few caveats to this topic. So the first caveat is, you know, if you've already decided this is neoadjuvant chemotherapy, which by definition means that you're going to offer the patient surgery, then a response for complete clinical response, you know, is completely irrelevant because you've committed the patient to surgery. I think the real question is, you know, how reliably can a complete clinical response predict a pathological complete response? What we really want to know, or the take home from this message should be, you know, how can we avoid surgery in a patient? So what steps can we, it doesn't matter if it's 41 gray, it doesn't matter if it's 50 gray. Can we reliably predict PAT-CR? Because 50%, even with a 41 gray, gets PAT-CR. Would you want to offer them surgery? So what are the current modalities for assessing a complete response? Patients with complete clinical response have comparable survival with PAT-CRs. And finally, the question, you know, a patient with a complete clinical response, should they have esophageectomy? The three questions we're going to try and touch on. Maybe we won't reach a consensus in this talk. The response evaluation. So we could do a CT scan or a PET CT scan. We could do the standard ways of evaluating radiological ways of evaluating for response. Some centers do EUS. We have to confess, in the UK, we don't do EUS necessary for a complete for response. Obviously, luminal response could be done using endoscopy with or without biopsy, US guided, you know, biopsy. And I'm going to touch on this unique, you know, new thing called the cytosponge. I think the first question is, you know, does radiology on its own, can it give us a reliable detection of a complete pathological response? And I'm going to touch on a few systemic reviews and meta-analysis. In the first one, this is from 2019. It looked at all neoadjuvant therapy, so not specifically at chemo-RT, chemotherapy and chemo-RT. And you can look on at the side, you know, of the sensitivity and the specificity of the various modalities. And basically the answer is no. The current modalities as single agents are insufficient to identify complete responses. So this meta-analysis, which was published last year, is actually more focused on neoadjuvant chemoradiation. And it looked at 44 studies. And they were actually, they added in the endoscopic biopsies, which were the standard endoscopic biopsies, the qualitative EUS or EUS for nodal disease, and a variety of PET modalities. And once again, just using these kind of modalities, the conclusion was it was insufficient to accurately make a prediction of complete response. So I'm going to come on to another meta-analysis, and this is a meta-analysis which is different in that it looked at patients who had a complete response after chemoradiotherapy, and what is their outcome, and whether there's a difference if they have surgery or not. So the difference, it is not a randomized study of DCRT versus NCRT. These are the patients who are selected after having a complete clinical response based on their criteria in these studies. And this is a study, meta-analysis, which had over 600 patients, but they're all retrospective, and there are 4 studies. Well, the conclusion, I suppose in a way is irrelevant because that's not the question of my talk. The conclusion was that actually adding surgery does not necessarily add a lot to the survival, but it does add to the disease-free survival. Maybe kind of approach may be better for squamous cell cancer, but then again, that is not the topic today. The topic is all about, can we predict complete clinical response? So if you look at these studies in a bit more detail, so this is the first of the studies, and this is a study from the Italian group. So patients had they all had chemoradiotherapy. They then had a look at for response. If they had a complete response, they were either, this is not randomized, they either proceeded to surgery or did not proceed to surgery. So you can see the overall survival was the same, which is the graph on top. the disease-free survival, there was a tendency to be better if they were in the surgical group. But again, the thing in highlight that the complete clinical responders, 31% of them had a residual disease. So yes, you got it wrong in 31% of cases. Second of the cases of the studies, slightly bigger study with 160 patients. Again, the overall survival and the disease-free survival, whether you had surgery or not, seem to be very similar. But mind you, this one actually highlights that those who had a surgery comparable to surgery, to the surgical series, was those who actually had a good follow-up strategy and had surveillance and salvage radio surgery in a group of patients. Those who did not have salvage had a pretty poor outcome. So the third, this is the biggest of the studies from the French group, from Christophe Mariette, who unfortunately died a few years back. But he was a fantastic surgeon and has done a huge amount of work with PCRT and salvage surgery. But this was the only study actually which showed a clear benefit in patients who had surgery. But again, topic, 36% of the patients had residual tumors. And the fourth of the study, and this is interesting because, whereas the other studies, the radiology was a mixture of CT scan or PET scan, but this study basically mandated PET scan as a way of assessing response. And what was interesting is in this study, it did show that those who had CRT only had a poor survival. The 2-year survival was 37 versus 60%, or 35 versus 2-year DFS was 35 versus 72%. But if you look at the group who had a metabolic complete response, if you look at the 2-year survival, it was 61% versus 60.3% in the CRT surgery group, which kind of suggests that maybe there is a role of using using metabolic complete response as a marker of selecting. In any case, again, the question is, was the response able to predict residual tumor? Again, 57% of them. Now, why? So there's a variation, somewhere between 30% to nearly 60%. And I suspect the variation is due to the mixture of either adenocarcinoma versus squamous cell cancer, but also how well was the local area sampled. So in summary from the previous studies, the metabolic complete response may be a marker, but in general is a poor marker. Over a third of the patients who had so-called clinical complete response actually have pathological residual disease. And there's an interesting question here, is the, those who have pathological residual disease, is it because the tumor is all on the surface and you just need multiple superficial something? Or is it because the tumors are in the deeper layers, which means you need deeper biopsies? And I think third thing, which is fair to accept, that if you're going to have TRG2, which is scattered cells here and there, no amount of clinical assessment will be able to pick it up. But really does picking up TRG2, if you miss a TRG2 and call that as a complete clinical response, does it matter? And interestingly, this is the OEO5 study, which actually looked at the survival of those who had TRG2. Their survival was pretty identical to those who had PAPS. I suppose you can afford to miss those patients who had a TRG2 tumor, call them complete response. Controversial, maybe. Now, so just going to the more interesting bits of the question. So the question is, if we are going to develop a strategy whereby you want to avoid surgery and going to maximize your assessment of complete clinical response, you need to know where actually are those residual cells left. This was a study undertaken by the Dutch group, by Shapiro. It's the same group that did the Cross group. And what they looked at is they mapped where the cells were in those who had pathologically incomplete response. This is a study of the 102 patients. Those who had 71 of those had a non-complete response. They mapped where the cells were. And what was interesting was that nearly 90% of them, the residual cells, were in the mucosa or in the submucosa. There was only 5% where the cells were purely in the muscle without actually involving mucosa or submucosa. And only 3% had lymph node-only disease. Kind of suggesting that if you can very well do a good trolling of the mucosa, submucosa, you might be able to get a better idea about the complete response rather than having to drill deeper down and take muscle biopsy. So that was very helpful. The other thing is, they even looked at what happens if it was a T1, T2, pre staging versus T3, and it seems like the distribution between in the residual cells, whether it was T1, T2, or T3, was very similar. Whether it was squamous or adenoma, it was very similar. So here we've got some kind of an idea. If we want to improve our accuracy for clinical complete response, we need to target the mucosa and the submucosa better. So that actually, is led to the pre-Sano study, and all the data, we talked about had actually came up slightly, in parallel with the pre-Sano study. So in the pre-Sano study, effectively the patient had chemo-RT and had two clinical CRE, which is a clinical response evaluation. And the first clinical response evaluation, which is an endoscopy, if tumor was found, very simple, they went for surgery. Now, if they did not have any tumor found at that point, they actually had another six weeks of wait. The total wait from neoadjuvant CTRT to surgery was now 12 weeks in that group of patients. At that point, they also had the CRE2, which is the clinical response evaluation 2, where they had a PET-CT, endoscopy, EUS with FNA of all suspected nodes, but they also had surgery in these patients so that they could compare head-to-head what happened to those who had a so-called complete clinical response and could compare with pathological response. So in the initial part of the pre-Sano study, they were doing standard biopsies. And what ultimately comes up is that if they were doing the standard biopsies, they were still missing about 30% of the cases. So which is exactly what we've seen in the other studies. And when you say missing cases, this is looking at TRG 3 and 4. The TRG 2, as we said, is they've accepted is the same as having aphasia. But halfway through the study, they realized they modified their biopsy techniques and started doing these tunnel biopsies or bite-on-bite biopsies, which is basically they do a biopsy and using that biopsy hole do another deeper biopsy. And when they modified that biopsy technique and then they started doing the study, they found that the false negative rate was down to 14%. So here you have a situation that you can tell a patient, you had chemotherapy, CTRT, we have done this kind of proper PET, US, FNA, and this kind of bite-on-bite biopsies, there is now a 14% chance that you've got tumor left behind. That's a completely different kind of discussion with the patient, whether he wants surgery or not at that stage, versus telling someone you've got a 30 to 40% risk of tumor left behind. The other interesting thing here was when you look at what happened at 6 weeks, there was 39% of them had tumor left behind. 12 weeks, it had dropped to 20%. So overall, surgery at 6 weeks, maybe 4 to 6 weeks, maybe a bit too early. Maybe it is possible that surgery at around 10 to 12 weeks may be a better time point if you're looking for aphasia. I mean, I suppose if you want surgery, it does not really matter. But if the patient doesn't want surgery or if you want to avoid surgery, the assessment at 6 weeks may be a bit too early. Maybe they need the assessment at 12 weeks. Now, how did the PET or the EUS contribute to all of this? Well, it's safe to say that the PET was pretty useless in trying to determine whether the patient had a complete response. But they used the PET as an effective way of picking up metastatic disease. It picked up about 10% of cases had metastatic disease of PET-CT at this stage. Now, also interestingly, if you did an EUS for restaging, and if you just based on EUS thickness, they missed about 28% of the cases, which is the same as exact normal biopsy. So again, EUS may have a role, but not a huge role in this. So the overall conclusion was the PET-CT is not accurate. FNA cytology of the suspected node did add some value. Regular biopsies is not accurate, and therefore bite-on-bite biopsy should be considered. It reduces the false negative rate to a point where you could start having some discussions about definitive chemoradiotherapy and avoiding surgery. So I'm going to touch on this cytosponge, which is something we've been doing in the UK. The cytosponge is basically a sponge in a capsule. You patient is tied to a string. patient swallows this capsule with the sponge. The capsule dissolves, the sponge pops out, and then you basically scrape the sponge up, and then you put it in a pot and send it for analysis. So if you think when you look at the spread of cancer, we said that 80 to 90% of this cancer is going to be at the mucosa or the submucosa level. Therefore, if you have a device which completely controls the mucosa and potentially the submucosa, you might have a better accuracy of picking up the residual cells compared to just biopsies, which obviously you're going to do, 8, 10, 12, 16 biopsies. So the cytosponge has been used a lot for Barrett's in thousands of patients by Professor Rebecca Fitzgerald from Cambridge in Barrett's esophagus, but has never been tested for esophageal cancer, and certainly not for TB assessment. So, and as a test for Barrett's esophagus, it was a pretty good. It had pretty good sensitivity and specificity. So we did a study where we looked at the cytosponge to test for post-treatment assessment for residual disease. Now, I mean, we finished the study. It was 41 patients had been recruited from 11 centers across the UK. We were looking basically to see, after CTRT, is the patient able to swallow that kind of a capsule or a sponge? We're effectively looking for completion rates, acceptance rate, and also looking at, the suitability of the biomarker and whether we can pick up cases. Well, I mean, this is going to be presented at a World GI Congress. I mean, so I can't really give the full data yet, but all I can say is certainly it's safe. Very little toxicity was seen in that. We were looking for, people who are successfully completing the cytosponge in over 70%. This was over 90%. And there have been very interesting data coming out of the comparison with endoscopies, because the patients either had endoscopy or surgery and get compared with the biomarker. There's really interesting data coming out. So anyway, just going to where we are with clinical complete response and how we're taking it forward. There are two studies. One is the SANO study, which is exactly the pre-SANO, but in this case, it's been randomized. Those who had a complete clinical response are either going to have surgery or fairly active surveillance, which is PET-CT every 3 monthly, endoscopy with bite and bite biopsies every 4 monthly for the first 2 years, and then basically 6 monthly. And there's the other study, which is called the NEED study, which is a German-Swedish study, and very similar, but this is confined to the squamous cell cancer patients. And again, the patients have been randomized up front to either neoadjuvant CTRT, and then being followed up, or they're giving a definitive CTRT, which is proper 50 gray or 54 gray. And those who have a complete response are being followed up. They also need bite and bite biopsies, etc., and they're being followed up with a very similar surveillance protocol. So, in summary, I'd like to say, ascertaining clinical complete response for CRT still remains a challenge, although we think we are getting there and getting more and more accurate. Multimodality treatment of, assessment of radiology and luminal assessment is going to be required. An extensive sampling of post-radiation tumor bed may reduce the incidence of false negative. And I think we are in conversation with the NEEDS group, and we are planning the so-called Cytoflock 2 to see what role cytosponge has in adding to the standard biopsies in these patients. The trials of intensive surveillance is ongoing, as you saw, and given the high QAT-CR rate, which is about 50% in squames, I think such a surveillance strategy may be more appropriate in SCP rather than AC. And I have to say, in the UK, we are open-minded. We've been hit by COVID. A lot of surgery was cancelled. During the last couple of years, we have been doing, quite a lot of definitive radiotherapy and putting patients on that kind of a surveillance program. So we are very open-minded about whether surgery is required. The only thing is, I think as we talked about, is the dose 41.4, I find very uncomfortably low, although I have no rationale to believe that. So I tend to give 45 gray as my neoadjuvant dose, or if the surgeons are not really sure, whether they're going to operate or not, I do give 50. I don't give 50 because for, I think, 50 perfectly safe dose. We've never had any problems with that. Because in fact, in the scope 2 trial, which is currently ongoing, they're giving 60 grain 25, and we have not seen much. There are several analyses, and we have not seen in 25, mind you. So the results. Thank you.
It has been a very useful talk, Professor Mukherjee. Now questions will come your way from the discussants. And discussants are Dr. Kanika, Dr. Ajit, and Dr. Pritanjali.
So, if I may ask Dr. Somnath, it was a very lucid and illustrative lecture on what is complete response and how you can, the challenges that we come across in seeing the complete response happening after a neoadjuvant CTRT for esophagus. Can you just discuss or put light on if there's any role of radionomics or even AI for predicting the response, and also whether there are any predictive models that are there already that are ready to be validated for the same?
So, I mean, certainly radiomics and or genomic radionomic combination, radiogenomics, are an interesting area. But all I have to say is these are all very experimental modalities at the moment. In the squamous cell, you might be aware of Rebecca Fitzgerald's works in terms of genomics, into dividing these tumors into a group which is more likely to be ER positive, a group which is more likely to be the mutagenic, where immunotherapy will work. And certainly, whether we use the primary genomic to then target patients with either radiation with an ATR inhibitor, which we in the DDR group, or we use immunotherapy in the mutagenic group, is of interest. I mean, we've just finished phase 1 study for combining immunotherapy with radiation, and we will be looking at mutagenic group. And I have to say, these patients, I remember a patient who had 2 weeks of immunotherapy, even before starting chemoradiation. And when it came to the first fraction of chemoradiotherapy, they couldn't find the tumor on the cone beam CT. I had to replan this patient. The patient probably never had a dose of radiotherapy. The tumor completely dissolved, it disappeared after 2 doses of immunotherapy. So there are these groups of patients, but we don't know. There's a lot of study going on, but as I said, even with radiomics, I mean, it is very difficult to be predicted down to that kind of a level. I mean, and with AI, as you know, it's a way of predicting the histology based on endoscopic images, and they're all we're doing some work on that, but I think it is very, very, very early stages. But all I would say is anyone doing any study looking at these kind of correlations between standard endoscopy, clinical assessments with surgery should build in radiomics or the radiogenomics as a part of their sub-study, so that we have a lot more data.
Okay, thank you. And could liquid biopsy add on to your prediction?
That is a very interesting. I actually had a little talk, a little addition about looking at ctDNA, and again, it is an area of interest. Looking at ctDNA, we have been looking. We've actually for cytosponge, the cytoflop study. At the times of analysis, we have collected blood for ctDNA, which is really interesting because we've collected. We haven't analyzed that data yet. We certainly have had studies here which have looked at ctDNA after surgery, and those who have positive ctDNA at surgery have a worse prognosis. And then if you monitor patients with ctDNA, ctDNA starts rising before they actually have clinical relapse. But if you have a complete response on on your clinical criteria, or not, and you have a ctDNA positive, would you stop the patient having surgery? No, or just saying you have a complete clinical response and you have a ctDNA positive, would that patient go to surgery, or would you observe the patient? I don't think we know the answer. I mean, at the moment, we would probably ignore the ctDNA and just and follow them through.
Thank you so much.
Dr. Somnath, there was this question, and which was also common to Dr. Naveen. He had asked it in the chat box that you personally use a dose of 45 gray for the neoadjuvant chemoradiotherapy, right?
Yep.
So he was inquisitive to know, as well as myself, that could we escalate that dose of neoadjuvant chemoradiotherapy to say 50.4 gray, which is also used in some of the centers, or are you comfortable with 45 gray dose itself?
I mean, to be honest, the Americans use 50.4 gray all the time. So that's their standard chemoradiation dose. I think, well, I have no problems, and our surgeons have operated on patients after we've given them 50 gray. And what has been happening during COVID is we have been giving, because we were not sure whether there would be surgical spaces, we have been giving them 50 gray. I really don't think it matters. And I think increasingly, as we move to a point where we want to avoid surgery and clinical complete response becomes an important way, whether we choose surgery or not, we would be giving 50 gray, certainly, where people are a bit skeptical, want to maximize local response rates. Now, as I said before, I have not seen any data. There is some modeling data that, that Maria Hawkins, did to look at what is the dose escalation. And there's some study again from Birmingham, from the NGA, that there may be a dose response effect. But what it suggests is in the doses less than 40 gray, probably you have poor PAT-CR. But whether, how important is the incremental effect between 40, 45, 50, and 60? No, clearly we know from our data it makes no difference between 50 gray and 60 gray.
Would you use any clinical parameter to, guide these dose ranges from 41.4 or 45 or 50.4 gray? Would you adapt to say the tumor depth or the length of the tumor which is there, or the any clinical parameters like nodal involvement or something?
Those are very good questions. I mean, the thing is, nodal involvement, probably not, because even if I spoke to, the cross group, the Martens, they say at 41, most of the nodes disappear. If there's any cells, it is usually the primary which is there. Now, whether we use the tumor depth on a PET-CT scan or SUV max are all very interesting questions, but these are all very crude markers. I mean, do you use your genomics if you have a patient who is effectively has got the DDRD deficient? So they are going to tolerate, going to manage even with a smaller dose because they're more sensitive to radiation. Do you give them only, is there a role of de-escalation in that group of patients? These are interesting questions. And I think we need to be looking in those kind of ways where I would like to, the surgeons to forgive me for saying this, but there may be a role where the surgery becomes more of a salvage, like the anal cancer paradigm. And we focus more on salvage resection and intense surveillance where possible. I mean, it may be difficult in India where people come from a lot of places. But if there's a very good surveillance strategy combined with radiation, we may be doing all that kind of tweaking about the dosage. Personally, yes, you could, but I don't think there's a lot of difference between 45 to 50. So if the surgeon says, 7 times after 10, I would like to operate, I'd give 45 to the surgeons. I'm not sure is a borderline performance status, or I said I'd give 50.4.
Thank you very
I
much
think
for
we're
your
running late. We seem to be running quite late, already nearly 20 minutes late, and it will be midnight by the time we finish the whole conference.
So one small question, but just a small one. Okay. So first of all, I love the monthly of the literature you did, Dr. Mukherjee. Congratulations. Would this surrogate marker, biomarker-based, cytosponge-based methodology of surveillance replace biopsy? Do you think we could use that information to take decisions in terms of selection of patients for surgery versus surveillance? Or it would be just
well, at the moment, I don't think there's a good. I'm going to keep it brief, make it brief because of time. But I do not think there's a surrogate marker for endoscopy yet. But I think a combination of cytosponge and ctDNA may well be a surrogate marker. That is exactly what we're going to look for in cytoflock 2, or hoping to look for.
Any functional imaging which can add to the use
Well,
of these
the
biopsies?
functional MR, I think, of the imaging. I mean, I don't think the PET is pretty useless, and maybe there's an interest in DCMR, functional MR, as a modality on top. But I do not think it will completely replace some kind of histology, cytology based.
Thank you.
Thank you again, Professor Mukherjee, and the discussants, Dr. Kanika, Ajit, and Pritanjali. Over to organizers, please.
Thank you very much, sir. Thank you very much, Dr. Somnath Mukherjee. It was a wonderful lecture and a very nice discussion. I next invite Dr. Rakesh Kapoor to please call on the next speaker.
Now, I'll invite Dr. Viraj, who is a medical oncologist in Gujarat, HCG Cancer Gujarat. And I think most of the work which I have seen he has been doing on pancreatic cancers as well as the colorectal cancers. So Dr. Viraj is going to speak on concurrent regimens in esophageal cancer, carbopacli versus cis-5FU. Dr. Viraj, please. Dr. Viraj, can you hear me?
Yes, sir.
Yeah, please.
Good evening, everyone. Thank you for having me here. Since we are running short, I'll quickly go through over my lecture. I hope everybody can see my screen.
Yes.
So my
visible.
Right. So my today's talk is on a very specific topic, concurrent regimens in esophageal cancers. Do we use paclicarbo or cis-5FU, which was one of the questions during the panel discussion. Let's try and answer this. But for next 10 to 15 minutes, what I was thinking is we'll run through some historical perspective. How did all chemotherapy came into picture for esophageal cancer? Then we'll try and hit the answer for carbopacli versus cis-5FU. And then perhaps we can discuss a little bit further, how can we improvise the current techniques what we have today. So this is where all started, where in anal canal, we had a Negro regimen where MMC5FU showed amazing response along with radiotherapy. And the researchers thought, why not try this for esophageal malignancy? So this was the one of the earlier papers from 80, where people wanted to try how about adding this chemotherapy regimen, what we use for anal canal for esophageal malignancies who are not operable, and suddenly found 1 year survival of 73%, which was not what was commonly found in esophageal cancer in those days. Then subsequently, we had a seminal paper for all radiation oncologists. We know this 8501, where radiation was head-to-head combined with radiation plus chemotherapy, in this case cisplatin plus 5FU. And we all know that this is in the standard textbooks of all the books that we read in oncology today. So this actually laid the ground that cis-5FU plus radiotherapy is the standard of care for patients who do not go operation for esophageal malignancies. There were multiple studies they wanted to ask whether this regimen could be way to go for neoadjuvant regimen as well. So this was a meta-analysis which asked that if we added 5FU cisplatin to radiotherapy before operation, did it have any impact? There was a trend towards improved survival. However, there was no clear-cut survival advantage of adding cis-5FU in a preoperative setting rather than a definitive setting. Meanwhile, we had a drug called paclitaxel, which came in 90s. It's a microtubule stabilizing agent, works at G2M phase, which we all know is an excellent radiosensitizing phase. And there were a lot of trials during 90s for lung cancer, along with radiation during using paclitaxel. So one of the group from Dutch wanted to try and ask this question, can we use paclitaxel for esophageal cancer, since we could use for lung cancer, in the setting where one could do operation, not in a definitive setting. And in the initial 50 patients, what they found, of course, in West, we have more adenocarcinomas. from where we have this 41.4 grades in 23 fraction. What they found was PAT-CR rates of 25%, endoscopic complete response of 20%, and a 3-year overall survival, very, very impressive, of more than 50%. So these numbers were not seen earlier with any of the regimens, and hence this group decided that we want to go ahead and launch a phase 3. And this is the trial which we all know, the cross regimen, which clearly showed that comparing surgery alone, if you do neoadjuvant carbotaxol plus radiation of 41.4 gray, your survival is improved, more so in squamous cell malignancies. So with that, what do we do with carbopacli versus cis-FIFU? So with this background, let me tell you, there is no bang on head-to-head comparison asking in a setting, preoperative setting versus definitive setting. One of the studies from MD Anderson tried to ask a similar question, but messed it up. I must say, in a way, the setting was slightly different. It was induction chemotherapy followed by definitive chemoradiation, more of adenocarcinomas. And in this particular study, they wanted to ask, could we omit FIFU from the regimen? Unfortunately, the patients who did not receive FIFU, that means only paclitaxel and cisplatin, they did not do well, while patients who received FIFU, they did better. Now, mind you, this also had preoperative chemotherapy phase, and also there were more number of adenocarcinomas. So one of the trial certainly said that one must be careful in not omitting FIFU along with radiation. Then we had a nice study from France asking that if you want to use cisplatin FIFU, could you change it to FIFU plus oxaliplatin like we use for gastric cancer? And certainly in this concurrent regimen, definitive chemoradiation plan in adenocarcinoma, if you are using cis-FIFU versus FOLFOX-like regimen, the survival results were almost similar. And you could see the toxic deaths were far lower. This is commonly what we see as a medical oncologist. Cis-FIFU is far more toxic as compared to FOLFOX. FOLFOX is far better tolerated. Another study, which was KELJV, which was trying to ask, should we do carbotaxol or should we do FOLFOX? Mind you, again, these were all adenocarcinomas. This study wanted to have a PET-CT guiding the treatment. So patients underwent FOLFOX induction chemotherapy. If they responded, they continued FOLFOX as a radiation partner, and they were evaluating PAT-CR. While if patients did not respond, they changed the chemo combo to the radiation partner to carbotaxol. And the other hand, you started with carbotaxol, you do respond, you continue carbotaxol, and if you don't respond, you go change it to FOLFOX. So slightly difficult study design, but very interesting study asking the right question. And what one found in this study is that if you are starting with FOLFOX chemotherapy in adenocarcinoma, whether you respond or don't respond, eventually you will end up in better pathological complete responses as compared to if you were to go with carbotaxol. And that was later on shown to even translate into overall survival advantage. So this was the arm with FOLFOX. If you respond or not respond, your numbers are still better than if you were to start with carbotaxol. Now, mind you, again, this is for adenocarcinoma and may not apply for squamous cell malignancies. This was one of the latest study from China asking, could we omit platinum completely? You know, just do FIFU with platinum versus FIFU plus paclitaxel. And what they found that they were all same. So paclitaxel and cisplatin in this study were interchangeable, but FIFU was a common partner. The problem with this study was the dosing. The dosing of FIFU used in this study is something what we as medical oncologists don't use, like 1800 per meter square over 72 hours. That's a very minimal dose. And 300 per meter square daily dose from 1 to 4. Again, it's a very minimal dose. That's not the dose that we use if we use this FIFU. So if I have to put a verdict for squamous cell carcinoma based on cross regimen single-handedly, I think so it's a still way to go regimen, especially when you are doing pre-operative setting rather than definitive setting. because the comfort of toxicity profile. And like Dr. Mukherjee said, I am yet to know any clinical trial which has 50% PAT-CR rate in squamous cell malignancies with this 41.4 plus carbotaxol regimen. For adenocarcinoma, I always have a fight with my radiation colleagues in my center. I do prefer perioperative chemotherapy rather than a preoperative cross regimen. But if I have to use chemoradiation for adenocarcinoma, we use FOLFOX as a partner with radiotherapy and not a carbotaxol. Just to wrap it up, where are we moving with this chemoradiation in esophageal malignancies? To start with, our own Tata Memorial study, which was presented just a few months back in ASCO GI, where these patients all had definitive chemoradiation, and after definitive chemoradiation, they were randomized to oral metronomic chemotherapy, like one would get for head and neck, versus observation. And quite a few number of patients, 150 number of patients. And what they found out was that not only it was beneficial, but it was slightly detrimental to use oral metronomic chemotherapy after definitive chemoradiation. So certainly something which we must keep in mind. We must congratulate TMH people to conduct this study. However, oral metronomic chemotherapy is not the way to go for at least esophageal malignancies. Similarly was the fate of cetuximab. It was tried in SWOG study, it was tried in SCOPE study. Europeans and Americans tried adding cetuximab with various combos. Unfortunately, none of the studies showed any advantage in any of the survival endpoints. Just like we had benefit in head and neck cancer, we didn't find any benefit in esophageal cancer. Very recently, last year in ESMO, we had addition of trastuzumab in patients with HER2 positive GE junction. If you do cross versus cross plus trastuzumab in HER2 positive GE junction, there was no benefit compared to cross alone. Again, this was a big failure. One thought that targeting HER2 would be beneficial, but unfortunately it was not, and this is dumped forever now. What is exciting is the last few slides is on immuno-oncology. Medical oncologists never stop without talking immuno-oncology. We know nivolumab has a recent FDA approval for squamous cell lung cancer as well as adenocarcinoma of gastric and esophageal cancers. Radiation oncologists love this word called mole effect or abscopal effect, where you try and radiate one place and the benefit appears somewhere else. Anyways, we have phase 1 studies and preclinical studies where combination of RT and this PD-1 treatments has shown to improve PD-L1 expression, and hence one can postulate that perhaps targeting PD-L1 along with radiation could make sense. We also proved it in lung cancer. So in lung cancer, it is approved after chemoradiation in stage 3. One does give adjuvant radiotherapy, so-called pseudo-adjuvant. So people wanted to try, will that be useful in esophageal malignancies? There are several phase 2 studies undergoing already with all of the 4 immuno-oncology molecules that we know today. What was impressive was this Checkmate 577 study, which was presented again last year ESMO, where after completion of cross regimen and operation, if patient had a residual tumor, means they did not get a PAT-CR, they would either get 1 year of immunotherapy versus observation, which is what standard practice is today. And the striking feature was there was a doubling of PFS or disease-free survival, I must say, from 11 months to 22 months. We have not seen such dramatic improvement in survivals in any of the recent trials. So based on this, BMS have filed for approval in this setting. And what was impressive was there was no correlation between PD-L1 positive or PD-L1 negative. The benefit was across both groups. But the node positive ones, which are very poor prognosis, we all know, tend to have a better benefit with nivolumab rather than node negative one. And squamous cell histology showed a better benefit as compared to adenocarcinoma. So with this, I thank you for your patient listening, and we can have discussion.
Dr. Viraj, I'll not waste any time now because we are already late. So I'll invite Dr. Pradeep, Dr. Abhishek, and Dr. Shefali as discussants, please.
Yeah, so Dr. Viraj, very nice presentation. So I have a question, right? Rather than simply getting away that, okay, carbotaxol versus cisplatin 5-FU, how to choose maybe may not sound simple, but can defining or selecting the patient on the basis of, say, borderline resectable or potentially resectable, like we do in pancreas, will sort out our matter. So if the patients who are potentially resectable, but because of the few nodal positivity, if we give the chemo radiation pre-op and choose carbotaxol just to, because they have a lower toxicity, carbotaxol, and tolerated well, will sort out the purpose versus heavy nodal burden and locally advanced disease where we are not sure whether we'll be achieving that response. So giving cisplatin 5-FU would solve the purpose, because we knew that, I mean, the PCR rates and the systemic chemotherapy coverage is better with cis 5-FU. So what is your take on that?
So regarding PCR rates, I'm not aware whether cis-5 along with radiation has more than 50% PAT-CR. Like Dr. Mukherjee said, cross regimen still date remains the best regimen for PAT-CR. So if you have concerns about conversion, I think so carbotaxol is way to go. How I practice is in adenocarcinoma, carbotaxol is a weak regimen, like you rightly said, and the recurrences are more distant rather than the local failures. So this is where we either do perioperative chemo, or if at all we want to do radiation, we do FOLFOX, and we have a CALJB trial to support this. That FOLFOX is way to go along with radiation if you are planning radiation at all.
So in distal esophagus carcinomas, I mean, I think only getting away with peri-op chemo is not the right way to go, because it is more of the G junction and the gastric part where we use that perioperative with confidence. So if it is a mid to distal esophagus, I think the trial also showed no difference between the pre-op chemo versus pre-op CRT, and then you cannot compare the PCR rates in both of them. So what do you think?
So now we are waiting for the pre-op chemo FLOT versus cross regimen. The we are still waiting, so we don't know the answer. Number two, FLOT study did have almost 30% of patients of lower esophagus and CWAT 1, 2, G junction. So again, we cannot say that FLOT does not work for these type of tumors. I think so we'll have to wait and answer. As a medical oncologist, I am more biased towards peri-op chemo rather than cross regimen.
All right. Okay.
Congratulations, Dr. Viraj.
Thank you.
Congratulations, Dr. Viraj. Hello.
Yes,
you are audible.
You, Pradeep, you can go ahead.
Go ahead.
You have given beautiful talk regarding the use of cis-5-FU versus paclicarbo in concurrent setup. But my question is, when the patient of esophagus comes with advanced disease and where cancer cachexia is there, or patient have on liquid diet only, should we go with one drug? I think one drug is tolerated very well as compared to two drugs in those cases. Or sometime if patient is even not able to tolerate cisplatin, we have to go with capecitabine in tablet form.
Yeah.
So have you experience of these things?
Absolutely. So what you say is a very common problem. People don't seek medical attention, and when they come, they have dysphagia grade 4 and cachexia. Nutrition is a problem. So these patients typically go RT alone, along with low dose cisplatin. I never use capecitabine for squamous cell malignancies, but if it is an adenocarcinoma, it is okay. For squamous cell, if I have to give chemo, bare minimum is cisplatin, like we use for head and neck cancers. Otherwise, carbotaxol, I think so all medical oncologists now are very, very comfortable with it. It's a very, very low dose. But the patient you described, grade 4 dysphagia and cachexia, I think so this patient will end up getting palliative RT alone.
Thank you.
Other questions, I'll hand over to the organizers. Dr. Divya, please.
I think Dr. Somnath Mukherjee has a comment to make. He has put it in the chat box also. Dr.
See,
Somnath?
Viraj can answer. Viraj can answer in the chat box. He can answer in the chat box. We can go ahead further. Let him
Okay.
answer in the chat box.
Okay.
Yeah, let us proceed. Let him answer in the chat box. Viraj, please answer in the chat box.
Yes, I will.
Thank you, Dr. Viraj. And now I request Dr. Rajesh Vishishta sir to please invite our next speaker.
Okay. Now we have listened the chemotherapy and radiotherapy, everything. Now we have to know how failure is occur and pattern of failure. For that, I invite Dr. Kaustubh Talpatra. Kaustubh Talpatra is the head in the Kokila Vein Cancer Hospital, Mumbai, and he is also heading chain of Kokila Vein Cancer Hospitals in Maharashtra. He will speak on pattern of failures of after neoadjuvant chemoradiotherapy and surgery in esophageal cancer and implication of portal design. Dr. Kaustubh. Dr. Kaustubh, please. Dr. Kaustubh, mute.
Kaustubh, you need to
Unmute your
unmute.
mic.
Kaustubh, unmute, please.
Unmute. Kaustubh, unmute your mic. Okay. Unmute. Again you mute. Okay. Go ahead.
Are my slides visible?
Yeah, visible, visible.
Yeah,
Please
yeah.
make
Thank
it
you,
full
sir.
screen. Make it full screen, please.
Yeah. Now, Kinjal?
Yeah, visible. It's visible. Thank you so much.
So I thank the chairpersons. I thank the organizers. I think it has been a wonderful academic feast and GI specific. It has been great. So my talk, as Dr. Vashish has said, is patterns of failure after NSCT-RT and surgery in esophageal cancer and its implications on portal design. Important talk, very complicated, very confusing, all contrasting data, and the audience is also varied. So I thought, rather than only discussing trials, I wanted to have some take-home messages for young oncologists, young radiation oncologists, and the students. At the outset, I would like to acknowledge Dr. Ashit Konda, Dr. Akanu Patro, Dr. Naveen Munmudi, and Dr. Anil Tebrewal for all the material they have provided me with. And before starting, let us get into why esophagus is different and why patterns of failure is an issue in esophagus. It is because of one, its rich mucosal and submucosal lymphatic system. And the second very important point is it has no serosa. So we all know what is squamous, what is adeno. I do not need to expand on this, and not it is beyond the scope of the topic. But what I am going to expand on is esophagus lacks a serosa, and it is neighbored by structures like loose connective adventitia. So the possibility of direct extension is very high. And we all know that it also has a possibility of hematogenous metastasis. At the same time, it has an extensive lymphatic drainage system. They are all intercommunicating and they have bidirectional flow. And that is why sometimes from a lower esophageal, though the percentage is very low, but from a lower esophageal disease, you will see all the nodes have been skipped and you have one supraclavicular node. Establishment of trimodality therapy, I do not think I need to emphasize on it, just 1 or 2 slides on it. Definitely lot of material is there which has shown trimodality is better than surgery alone, and you can see the p-values here. Similarly, trimodality versus definitive CTRT, the French study and the German study both have been landmark studies, and there also it has been seen that the trimodality treatment has fared better than definitive CTRT, except for one small subgroup about which we keep debating about that what happens to patients who have had complete responses. Patterns of failure, of course, with the intense neoadjuvant treatment, proper chemotherapeutic agents and good surgery, patterns of failure are all becoming haywire, in-field failure, out-of-field failure. They are all becoming lesser, but traditionally, squamous cell carcinoma had higher regional and supraclavicular recurrences, and adenocarcinoma had higher incidences of distant recurrences. But adenocarcinoma has also come a long way. There are newer drugs, so adenocarcinoma will be faring better in the next decade. So first, assessing the patterns of failure. That's the first part of my talk. And then I will be talking about the portal designs, which is the second part of my talk, and why go west when we have Indian data. Of course, retrospective, but this is by Shagun et al. And this is an assessment of retrospective assessment of 123. I'm sure Shagun will be somewhere and we can have a discussion later on the chat box on this. To cut the long story short, overall loco-regional failure was much improved in the group which received NACTRT, and even the distant metastasis failure was much better in the group which received NACTRT. Only regional lymph node failure, there was a non-statistical betterment towards the disease, which towards the group which received definitive CTRT. So if we see the 5-year overall median overall survival, of course, the group which did NACTRT, they did better. What were the failures? This is what we are interested in. In NACTRT group, in-field regional failure were 12.5% and out-of-field regional failures were 4%. Another Indian study, I mean, we should talk about Indian study. Of course, this is also a very small study from my alma mater, CMC Vellore, only 21 patients, but the gist is 6 patients had in-field nodal recurrences. All the 21 patients were with esophageal recurrences, 6 had in-field recurrences, and 4 had out-of-field recurrences. This is an important study. This is the patterns of failure of CROSS, which was published in 2014. It was 422 patients, and the median follow-up was 45 months, which is almost 4 years. The in-field recurrences there within the target volume was 5%, 2% in the margins, and 6% outside the radiation target volume. So to cut the long story short and to come up with a message that with the usage of neoadjuvant therapy, we are not getting loco-regional recurrences to the tune of 40% and 50% and 60%. Whether in field or out of the field, most of the studies currently are showing the recurrences are moving towards the zone of anywhere between 5% to 12% and 15%. So this we have to keep in mind when we are talking about our design of portal. So similarly, various studies, I have just enlisted all the studies. So is there a need for a surveillance in this treatment group, post-treatment surveillance? And Sudoku et al. Have come up in their study. Of course, I do not want to get into the details of study because it's, it talks of various things, and they have been trying to assess a group of patients who have survived more than 10 years. But essentially, their take-home message was only 2% patients benefited from post-treatment surveillance. So for recurrences and surveillance, again, there are the house is divided, and the surveillance strategy as it goes today, no randomized trial, no major data, and some groups suggest that the primary purpose of post-treatment surveillance is to potentially initiate a beneficial salvage strategy, which in esophagus often is not possible. But however, NCCN, which have religiously given a surveillance strategy, ESMO has been quite reluctant about giving a defined surveillance strategy, and they are saying the only possible exceptions and benefits may be in the group which are candidates for early salvage surgery. So coming for surveillance, I think most of our centers still follow to prevent, to detect early recurrences, a proper surveillance strategy, and even esophagus, they have been doing their investigations, imaging to pick up an early regional, local, or distant failure. Coming about the volumes, target volumes in esophagus, this is extremely important for the students because they are often confused about how to enhance the volume and how to draw the CTVs from the GTV. So only, what to draw for patterns of failure will come only when you know how to draw your basic GTVs and CTV. So the gross tumor volume is based on the extent of disease using the initial PET-CT, endoscopy report, and CT scan. Entire circumference of the esophageal wall needs to be included, including any disease that extends through the wall. CTV primary and CTV node. Of course, I'll be coming to the various studies which have been talking about it. It is GTV and 3 to 4 centimeter expansion superiorly or inferiorly along the level of esophagus and cardia, unless you are in the cervical esophagus where you stop at the level of cricoid cartilage. And if you are in the G junction, you try to go 2 centimeters caudally and involve the uninvolved gastric mucosa, and that's where you do not go 4 centimeters below, because it will be too much of a gastric mucosa which will be irradiated. There is a 1 centimeter radial expansion to cover the paraesophageal nodal region, including 0.5 to 1 centimeter expansion past any grossly involved node, respecting anatomic boundaries. You have to respect the curvature. Esophagus follows certain curvatures. So it goes into the midline for some time, then it turns left, and on T5 level, it again comes to midline, and again little lower down, it goes left. So your contours also have to follow those curvatures. You have to respect the subclinical lesions. This is an important topic. I am not going to the details, but the subclinical lesions could be intramural metastasis, multicentric occurrent lesion, microscopic lymph node metastasis, isolated tumor cell. So your CTV primary has to include the GTV primary and all these other things I have talked about, as well as the vascular invasion. Now you may come up and ask me, how do you contour vascular invasion? You know, it is empirical. I don't think there is any contouring guideline which is talking about a contouring of vascular invasion. But if you see on a grossly, if there is a vascular small vessel being involved, that complete vessel has to be taken into account. CTV for lymph node. We'll be talking about prophylactic lymph node radiation, but the lymph node CTV should be separate for upper thoracic, mid thoracic, and lower thoracic. And what should be the regional lymph node, whether you are doing elective or not doing elective, is your institutional decision, because there is a lot of controversy regarding that also. But you have to remember that your CTV nodal contour has to be separate for these 3 stations. I will not get into the details of that, but for cervical esophagus, you need to, if you are doing prophylactic, at least you need to contour this. For upper thoracic, this is what has been recommended. For lower thoracic, these are the nodal stations which have been recommended. For abdominal, these are the nodal stations that have been recommended. But you may just turn around and ask me, is prophylactic nodal radiation worth it at all or not? So this is one study which says that prophylactic nodal radiation is not necessary, and the basis of omitting prophylactic ENI, elective nodal radiation, is the recurrent pattern in field, which of late we have been seeing that even out of field recurrences pattern are less. The biological behavior of esophagus, which we saw that, you know, the patterns of skip metastasis and the overall toxicities. However, NCCN recommends elective nodal bearing node at least contour some nodal station depending on the node, which I have already discussed. So these are the nodal stations for cervical, this for the proximal third, this for the middle third, and this for the lower third. Field arrangement. This is where we had all started from, and this depended on what you want to save at what time, and when you want to save your spinal cord, how much of lung you want to fire, and this is where it had all started from. Few tips I will give regarding the contouring when we are in the era of your 3D CRT, IMRT, and CT-based volumetric contouring. I'll not get into the process, but few tips to the students. CTV should be oriented along the esophagus instead of a simple geometric expansion, and that is what I told please take care of the curves. Just don't, expand 4 centimeters up, 2 centimeters down, and you will see you are nowhere near the esophagus. So each slice has to be contoured. And, as your esophagus is turning towards left, you have to take that into the account. Proximal CTV margin, we have talked about the cricoid levels, and distal CTV margins also. In the abdominal, for G-junction tumors, we have talked about that it should not be at least 2 centimeters, but not more than that. Modifications to the CTV, you have to respect heart, liver, vertebral body, aorta, and lung, and it should not expand more than 5 millimeter into all these structures. Trachea, important. Often students ask, where shall we contour what trachea? So above the level of carina, you have to take the trachea in its totality. Sorry. Above the level of carina, you have to contour, the trachea has to contour, completely come into the CTV, but above the level of thoracic inlet, the trachea should be excluded from the CTV except for 1 centimeter radial margin. Proximal esophagus. So suppose your nodal recurrence is in the, suppose you have a N1 disease. This could be your treatment volume based on the NCCN guidelines and the guidelines that I have shown you. Distal esophagus. This is how the contouring volumes had developed, and this could be your treatment volumes based on the NCCN nodal stations that they have talked about. G-junction tumor. I'll show you. This is slides from Professor Pama, and Kanu has shared these slides with me. So for G-junction tumor, 3 centimeters superior, 2.5 inferior, 1.5 radially. We have all understood that. What I want to bring to your notice is, how do you contour your stomach region? 3 centimeter left from the last slice of GTV. So you contour up to the last slice of GTV, 3 centimeter into the stomach, and that is your 3 centimeter stomach region. And this is what, has been practiced for quite some time, and we have been following. Similarly, 1 centimeter CTV radial expansion. This is what it looks like. And finally, with your upper expansion, lower expansion, and the stomach 3 centimeter expansion, your final volume is going to look somewhat like this. Talking about PTV margins, of course, it is setup dependent, institution dependent, and you should have your own policies. So I will not get much into that. This is from the Wu et al., I think, and this is how they have given nice IMRT contours, and they have talked about 3 different case stories. So in the upper esophagus region, see how they have contoured the level 3 retrotracheal and the paratracheal nodes. Similarly, in this setting, in the mid-thoracic esophagus, they have contoured, this is how to contour the level 4 paratracheal node. And this is much lower down, lesser curvature, and this is how they have contoured the paracardiac nodes. These are the dose constraints. Now, this is the latest contouring guideline, and this is specifically for neoadjuvant target volumes in esophageal cancer. And I think, this guideline is a correction guideline for all the previous guidelines available. So this is important. Please go through this guideline properly. This is by Thomas et al., and which has been published in the Green Journal.
Dr. Kostev, I think we need to.
Yeah, I'm finishing. Just last 1 minute. Hello.
Okay.
Yes, please.
Just last 1 minute.
Please.
Last 1 minute.
Okay.
Yeah. So please read the concepts of GTV primary here, and they say that all these structures and all the nodal station should be included only till your expansion levels and not beyond that. And that is an important point to note. Rest of the guidelines are almost similar as what I have discussed so far. Salvaging recurrences with radiation. People are trying various things. So word about proton, it is important, it is encouraging, and let us see how it fares, but it has promise. So my take home messages are no consensus on ENI, but most centers practice regional ENI. However, with Thomas's guideline, I would suggest that draw elective nodes only till your expansion levels and not beyond that. For neoadjuvant radiation portal, contouring anastomotic site for the surgeon needs to be spared. Please remember that let us not be over enthusiastic and contour the anastomotic site. No consensus on surveillance strategy as yet, and newer radiation strategies definitely have promise for salvaging recurrences. Thank you.
Thank you, Kaustubh. Now invite a discussant, Dr. Nisa Vishnu, Dr. Anand Narayan, and Dr. Sujana.
Yeah, hello, sir. Thank you for a very exhaustive and extensive talk, especially because we as a radiation oncologist, and I really felt like a student today, listening to such an exhaustive and comprehensive talk. So I don't have many questions because everything you have covered in the talk. So the only question I have is, what would be your dose preference, especially in proximal esophageal tumors?
No, so currently for neoadjuvant strategies, I typically follow cross protocols. 41.4 with carbo, AUC2, Taxol and carbo, and 4 cycles of chemo, exactly as on cross protocol.
Even for the proximal esophageal tumors, sir?
Proximal esophageal tumor are not suitable for cross, as you know, because anastomosis is not possible. So proximal esophageal tumor, at least mostly 90% of them are for definitive chemoradiation. So definitive chemoradiation, my dose is 50.4 gray, but sometime, you don't ask me the my rationale and evidence because I'm from Tata. Sometime I just feel encouraged to push it up to 59.4 to 63, but most patients 50.4.
First of answer fast.
Okay, sir. Thank you.
Good evening, Dr. Kaustubh.
Hi, good evening.
Hello.
Ashwin, you go ahead.
Yeah. Good evening, Dr. Kaustubh. It was a good talk. Very difficult talk indeed. I have one comment and two questions. So one, we know that the lower esophageal tumors move a lot with respiration. So what would be your preferred motion management technique in those region? One.
Yeah, so Anand, currently it is 4D CT, and even in the guideline, ITV-based guidelines have come in the Thomas's guidelines. So we have just started following.
Okay. My second question would be, we know that adenos and squamous are very different, and most of the contouring guidelines are still common for both. Do you think it's time that we devise separate contouring guidelines for squamous, because that's the most common here?
It's time to devise one good contouring guideline. Till date, there is no good contouring guideline.
So where we can actually de-escalate the portal size and escalate the dose, because most failures are still in the GTVs.
But compared to the US standards, if we follow the UK standards, the scope 1 trial, the superior inferior margins are definitely less compared to the North American guidelines, because they advocate 3 to 4 centimeters superior inferiorly. But the scope says 2 superior and 2 inferior is sufficient. But yeah, it depends on, again, clinician to clinician.
Sir, this is Dr. Nisha Vishnu. I have a small question. It was a wonderful talk, by the way, sir. And one small comment is that with the T2 lesions having an occult metastasis level of more than 50% and T3 with more than 70%, what I have always seen is that elective nodal irradiation is by default practice policy till now. I don't know.
That's what NCCN also recommended. But there is data is divided, but in practice we have been doing, but let us not radiate too much. Maybe radiate till the level of your contours. That's it.
Yes, sir. One rule of the thumb that I've seen even in the Nancy Lee, there is a mention of that, is that if it is a supracarinal proximal thoracic lesion, then we definitely include the supraclavicular fossa And if it is an infracanal distal lesion, we tend to more include the abdominal nodes electively. So my question is that if there is a distal lesion and a PET positive, suppose a left supraclavicular node, then do you actually treat the whole, esophagus in between the paroesophageal, or you just
would you really take that up for a new CT, NSCT-RT? I don't think you should take it for NSCT-RT at all. If you have a supraclavicular node from a distant esophagus, I don't think it makes rational to take it for your NSCT-RT protocol.
We have taken such a case, and it was a conundrum for me as to what to do in between.
No. I mean, if someone is taking, definitely radiating the whole esophagus is not on.
Yes.
But should you really take it is my question. I would not. I would not treat that patient with a neoadjuvant radiotherapy.
Yeah.
Thank you, I want to make a comment. Kaustav, you do one thing. The point is to Kaustav and everybody, all the faculty, that after you finish your talk, please go to the chat box and answer the questions. Kaustav, you please answer the questions after your talk is over. You can answer the chat box questions, please. And all the faculty, after you finish your talk, you can answer to the chat box questions. Thank you, sir. Ashish sir.
Thank you, sir. Now, Dr. Kapoor, invite next person.
Thank you, Dr. Vishesh. I think the topic which has been given to the next speaker, Dr. Balu Krishna, is the most difficult one, because at the end of the day, it is the radiation oncologists who are getting most of the esophageal patients, and he is going to speak on deciding best neoadjuvant strategy in esophageal cancer. Dr. Balu Krishna, please. Dr. Balu Krishna is a professor of radiation oncology in CMC Vellore, and I think he has DMRT, DNB, MD. His life has been in CMC for a long time. So I think no one better than him can speak on the strategy which he is going to talk to us. Dr. Krishna, please.
Thank you for that kind introduction, and very good evening to all of you. So as you had mentioned just before that, it's a very difficult topic when I was trying to prepare it, but I hope I will do justice to it. And we have, sorry, my slides are not. Yeah, so we just heard three important topics on the same, that is, one is about assessing clinical response after neoadjuvant approach, another about concurrent regimens comparing paclitaxel with other regimens, and also Kaustav very nicely presented the patterns of recurrence that has come. So I have followed Kaustav in CMC, now I'm following his talk also over here, so that's nice. So my job is now to tell you what is the best neoadjuvant approach in esophageal cancer, and I assume that is inoperable esophageal cancer, and specifically squamous, because I feel that is more important in the Indian context. And based on that, I would try to answer these questions. So, what is the current practice that we all follow, and what is it in terms of Indian context? Where do the issues lie, and what is the best design in this context? This is what I'm trying to answer. And obviously, since 2012, when CROSS came out, we have been very happy about it. And there have been umpteen editorials. There have been a lot of validation studies which all say it is good. And why is it good? Because it's a good data. It's an economic approach, because the number needed to treat is 7. That means when you have 7 patients treated with the protocol, you save 1 life, which is very big in oncology. It fits the Indian population because the data is very strong for a squamous histology, not too toxic, and not a difficult protocol to administer, and supported by very, very, very strong data. And I don't know whether there are other randomized control trials in other sites which have as strong data as CROSS, because if you look at the median survival, especially in squamous, you have up to 7 years with a good survival benefit and with only a mortality addition of only 4%. And within the trial, the protocol completion rates were good, and pathological complete response was 29%. And that too, it is almost half of patients with squamous cell carcinoma had complete response. So what is it in Indian context? As part of preparation for this talk, I called up a few of my friends in different centers across India, as well as chatted with them, and to understand what do they do with neoadjuvant approach in esophageal cancer. So these are some of the responses I got. Some centers, they say they do only radical radiation for squamous esophagus. And if it is to go for a neoadjuvant approach, it will be neoadjuvant chemo only. Another center said that they use neoadjuvant chemoradiation only for short segment lesions and not for longer segment lesions. And as Kausav earlier pointed out, many centers don't do skip nodal metastasis. That is, if you have a lower third esophageal lesion with a higher mediastinal node, they would not do chemoradiation. Some centers said there is difficulty in scheduling radiation, scheduling chemotherapy, and then find a date for surgery. So it's easier for the medical oncologist to do neoadjuvant chemotherapy and then send for surgery. There are adventurous groups who actually do long segment esophageal radiation as a separate cohort, which probably would be discussed further in subsequent talks. And there are some people who have actually, the previous discussant actually mentioned about treating the upper third also in the supraclav region. Yes, so people have been having various approaches. And generally, one thing that they said is that the completion rate of the protocol in terms of completing all the chemotherapy with radiation was around 60 to 70%. And honestly, in my center, I don't think more than 50% patients complete 5 cycles of paclitaxel in a concurrent setting in a cross protocol. So what are the scenarios we hesitate to cross, especially the upper third location or a lower third with a high mediastinal node, a long segment disease that is more than 8 centimeter. Adenocarcinomas generally, because of the strong data with FLOT, now it goes, all of them go for a neoadjuvant chemo. Patient fitness is doubtful, and also radiation scheduling issue. So when I look at the ideal neoadjuvant design, I was wondering whether should we really alter the patient selection to fit the Indian population who comes to our clinics. Should we increase or change the chemo to increase response rates? Should we increase the radiation? Should we increase the RT field? Or is it that delaying and avoiding surgery is a good strategy after giving an intensive neoadjuvant approach? Or should be an ideal design which can treat all the locations of esophageal cancer? So if you look at cross, the tolerance to chemotherapy was 95%. So it's in a study setting. Compared to what we see in India is 60 to 70%, which is a crude rate I got from telephonic responses from centers. And the chemo delay was strictly due to thrombocytopenia, febrile neutropenia, and poor create clearance, which is also what we see in our patients, but maybe more frequently than in that trial setting. And we also, strangely, we also see a lot of default for surgery after neoadjuvant approach, because patients feel happy after the neoadjuvant approach, can start eating better. And when they are asked to come for a major surgery, many people default, probably because we have not convinced them enough pre-neoadjuvant chemotherapy. So then the larger question that comes to me based on this tolerance is, are we selecting the right patient? If you look at cross, the exclusions that are important to us is that when the patient presents with a weight loss of more than 10% of body weight, or a tumor length of more than 8 centimeter, or width more than 5 centimeter. These are strict exclusions in them, and which probably, if implemented in our setting, we may also be able to push our patients to a protocol completion. So another technical difference in cross is that they followed the AJCC 6th edition, and when we follow the current staging guidelines, wherein we find that the celiac node as well as supraclav nodes are not considered metastatic and they have good prognosis, they also deserve a radical approach with neoadjuvant chemotherapy. So can we use cross for them? This is a big question. And what about higher locations? Apart from the cross is generally a esophageal junctional study. So the inclusion of higher locations was less than 15%. And also in our setting, the surgeons don't want us to radiate the anastomosis. So these are scenarios where we have to find answers. The other question that I had to raise was, what is the radiation field adequate? So Kausav had just spoken about it. Yeah, he mentioned the cross recurrence rate. Generally, when we analyze the recurrence from cross, we find that the radiation field as well as the dose did not make a difference, because most of the recurrences were associated with systemic meds also. This was published later, and that 5% recurrences only occurred within the radiation target volume. Following the last GI oncology conference in MAX, where we discussed extensively about elective mediastinal nodal radiation because of paratracheal nodal recurrence, I went back and then analyzed our own recurrence pattern. And then we also could not find a convincing evidence to actually increase the radiation field beyond what is suggested by cross. So that's our data. And we have analyzed it across the PTV margins also, and we were not convinced that we should increase that. So what about increasing the RT dose? So following cross, actually, people have analyzed, especially in US, people have analyzed their database because they give a higher dose, and they have found that higher dose have actually caused higher perioperative mortality and not better results. So RT dose, so let's now look at whether Paclitaxel is the real answer. What is the alternative? Cisplat 5-FU? No, the perioperative mortality in Cisplat 5-FU is quite high. And even if you look at the Neoscope, our previous speaker who has published in 2017, that they have looked at comparing oxalic-capecitabine induction followed by oxalic-cape versus Paclitaxel in the Neoscope trial. They found Paclitaxel had better PCR rate. So it's a success story, Paclitaxel, and probably we don't want to take it off. So CROSS has the chemotherapy paclitaxel, which is given in CROSS, has given us good systemic reduction in metastasis and also good PCR. So should we move away from it is a big question. There are other trials actually looking at other chemo regimens like comparison with MAGIC as well as comparison with Cisplat 5-FU, but I think that is purely academic because we have moved on from these chemo regimens. So another question that I had is, can we import the total neoadjuvant therapy practice from another site to esophagus? That is by intensifying all the neoadjuvant therapy. Though we have the pre-Sano data, which showed that even if we do that, we cannot avoid surgery as of now, especially outside clinical trials. That is one direction that we can look at. So far, if I can surmise, there can't be any change to RT dose or RT field. Only thing that we could probably do is to intensify the systemic therapy. So that is where this trial comes in, FOLFOX plus RT versus CROSS, which is probably a modern chemotherapy than MAGIC or the Cisplat 5-FU. So this can be awaited in 2023. ESOPEC, which is including only mainly the adenocarcinomas, but the design is quite catchy for me because they are using FLOT followed by CROSS, which is also something to look forward to. Maybe in the Indian setting, our group should be able to do a trial on squamous cell carcinomas in the same design. Targeted therapies, nothing much to speak of because all of them are probably in the metastatic setting as of now. But these are all accelerated in trials now, so it may come up, but as of now, I cannot say anything can be added to the current regimen. So concluding, I would support the CROSS data very strongly because it is good, and if not the best right now. The data is so strong that it is very difficult to better this and then show a better result. So the only way we can actually avoid CROSS or show that something is better is that we can intensify and say that surgery can be avoided. So that is probably the way forward. So what happens to CROSS in India? Probably we are not adapting to the right patient. We should also have a separate cohort where we would actually use CROSS, which is actually tolerable, which is actually having good surgical results for long segmented diseases and unique situations, as I said, like higher mediastinal node and things like that. We also should have a proper nodal staging, which probably we may not have discussed earlier, maybe a good endoscopic ultrasound and FNAC of nodes before we go into do the neoadjuvant field designs. Intensify chemotherapy, the Neoscope model attracts me more, so I would look forward to that, the FLOT followed by CROSS approach. Finally, concluding, the right strategy if looking at these plates, if you are trying to save everyone with the same approach, it may not be right. So the right strategy to the right patient is what we need. And probably that's the direction we need to go in designing the next best CROSS. Thank you.
Sir, please unmute yourself.
Thank you, Dr. Balakrishna. It was actually a very good talk. It was very precise and to the point. So I just have one question. As you know, in CROSS trial, they tell they don't take patients more than 8 centimeters length of esophagus. But clinically, sometimes we do get patients of of disease of about 10 centimeters or more. So, in your clinical experience, do you think it is worth taking these patients for NACTRT, or it is better to offer them upfront definitive CTRT?
Okay, so I cannot answer from my experience because more than 8 centimeter, generally our multidisciplinary team diverts these to neoadjuvant chemo. But I can ask a question back to you. A suboptimal cross, is it better than a radical chemo radiation? So why don't we have a separate cohort of cross ineligible patients who can actually go for the same regimen and see whether their outcome is as much better than maybe pushing them for a radical chemo radiation approach, which probably does not have the same survival rates as when surgery is added. Maybe the future trials will tell us. So that's my answer to it. Yeah.
Fine.
Okay, Dr. Balu, that's a nice presentation.
Thank you.
My question is, what is your take-home message for perioperative mortality? Because neoadjuvant chemotherapy will increase overall survival or local control as suggested by recent meta-analysis, but it's on the cost of perioperative mortality. So what do you suggest? Although there was not much difference in cross-trial or neocritic trial, but meta-analysis suggests that perioperative mortality is quite high with this neoadjuvant treatment.
Yes, so that is across surgery alone. Obviously, if you have treated the patient upfront, the perioperative mortality rates would be there, which as of now, whatever data we have, the best perioperative mortality data is after cross, which is 4%. So I don't know. So as I showed you that plates, if you are going to try to save everybody by intensifying things, we are probably going to lose more when it comes to surgery or in salvage situations. So probably optimizing it to the right patient. And I am very happy with looking at the cross data and to use it. And I would like to, like all of us, to actually start stretching cross across inclusions that were not there in the actual cross trial, like more longer tumors and distant lymph nodes. That might help us. So perioperative mortality is best with cross, I think.
And anything will you like to suggest about type of surgery? Is there any guideline or any changes after neoadjuvant treatment, like number of nodes, dissection criteria, anything?
I may not be the best person to answer that, but whatever discussion I have had with our surgeon, because we have had isolated paratracheal tracheoesophageal groove recurrences in the upper mediastinum. But what our surgeons do is Mekions with two-stage lymphadenectomy. So beyond that, if you are pushing it, as you said, perioperative mortality may increase. So that's what my question of whether we should actually increase the radiation fields to actually cover for these recurrences. But again, now that we have better radiation technology, I would probably, the smaller numbers of recurrences that may happen in future, I would probably can salvage them with SBRT and things like that. When we have such options, it may not be prudent to put everybody through this toxicity to avoid recurrence in FU.
Questions, Dr. Pramod? I think if none, we can, Dr. Balu, thank you so much. It was a very nice talk. So I hand over to the organizers for the next talk.
Yeah, so we had a very nice discussion right till now. And now I would like to invite Dr. Indralil Malik, who is a senior consultant at Tata Memorial Center, Kolkata. And he'll give a summary about what we have discussed so far, starting from the talk where I started with a panel, and then we had a fantastic talks from Dr. Somnath and till Dr. Balu. So I would invite Dr. Indralil to give a summary on this. Dr. Indralil, please.
Good evening, everybody. It's a bit late, so I'll try to be brief.
Yeah, please go ahead. Yes.
So we'll start with the first talk where Professor Somnath Mukherjee took us through many interesting topics. He introduced PCR as very exciting because the rate of PCR after cross protocol in squamous carcinoma, which is our common, which is very common in India, is nearly 50%. I'd like to add by saying that even if we choose patients who are not cross-eligible, so in our experience at Tata Medical Center in Kolkata, about 30% of the patients we treat with cross would not have been eligible according to the eligibility criteria. We have had a complete pathological response of 40%. So it's very encouraging, and with just a dose of 41 gray, we seem to have hit the right protocol. We do know that pathological complete response does impact overall survival, and Professor Mukherjee explained that the research that is coming out and the analyses show that adding surgery to those who have had a complete clinical response or response on proper surveillance does not add to the OS, but does improve, adding surgery does improve the disease-free survival. We do not have a single good modality with which to predict complete pathological response, and clinical complete response can have false negatives. At least 30 to 40% have pathological disease. Metabolic CR on PET-CT may not be good predictor of pathological disease, but those who are false negative tend to be TRG2, and they may have some impact on the outcome that we saw. So people who've had a complete metabolic response may not have a very different overall survival outcomes compared to those who haven't. He noted that in residual disease, the residual disease is mostly in the mucosa and submucosa, and only less than 8 to 10% of them are deeper or in the nodes. And it does not seem to depend on the initial stage or histology. He summarized the pre-Sano findings, where about 30% for false negative with the standard biopsy, but with a bite-on-bite biopsy, this false negative rate dropped to 14%. And evaluation at 10 to 12 weeks had only 21% with residual disease. And therefore, there is a case for perhaps for delayed surgery. He noted that the PET-CT was not an accurate predictor, although an EUS FNAC from the nodes added value. Very interestingly, he pointed out to recent research with the cytosponge, where which could sample the mucosal and submucosal disease, and he told us about the cytoflock study, whose results will come up soon. The Sano study is ongoing, which is randomized between surveillance and surgery in those who have had a good clinical complete response based on an active protocol, and the NEED study, which of course is squamous only and was randomizing NSCT's surgery versus definitive chemoradiation. All this is very exciting because in the squamous cell carcinoma setting, this does provide us with an excellent opportunity for organ preservation once we know the results of many of these studies. We discussed dose in a number of the talks that have taken place, and this is still an unanswered question. We did discuss radiomics and ctDNA. My concern as an oncologist in India is that if cytosponge and ctDNA do turn out to be very good predictors, I have a feeling that this will add to the disparities that we have worldwide, because these two may not be easily available in our setting, and we'll have to find, either ramp up our services or find other surrogates. Going to the second talk on choosing concurrent chemotherapy regimens, Dr. Viraj gave an excellent summary with cis-5-FU, paclitaxel, and FOLFOX as the options. He pointed out to the background with the RTOG 8501 and the 0113, where we set cis-5-FU as the initial standard. He talked about Prodigy 5, where FOLFOX was compared with cis-5-FU. He did point out to the CalGB study, where FOLFOX seemed to be better than adenocarcinoma, but conversely, there was discussion on the Neoscope, where OxCap was worse than paclitaxel. He pointed out to research on oral metronomic chemotherapy, which doesn't seem to work, on cetuximab in the SCOPE and SWOG studies, which doesn't seem to work, as well as trastuzumab in the HER2 positive adenocarcinomas. But there is very interesting data coming up with the Checkmate 577, where nivolumab in the adjuvant setting for a year after cross in the PCR negative group has doubled the DFS and may turn out to be a standard of care. In terms of the patterns of failure, Dr. Talapatra gave a very good lecture, especially for the students. He pointed out to the lymphatic distribution. He pointed out to cross-failure data, where what was interesting was that the difference between the surgery arm was in the out-of-field nodal failure, which has sparked a lot of discussion on whether we should expand our nodal contours. He pointed out to two very important papers from India, from SGPJ and CMC Vellore, where they have looked at the nodal failure rates in terms of local regional failure. He pointed out that the surveillance strategy is debatable and variable, but what does turn out from most of the data is that distant failures predominate. So it's unclear whether changing portals will actually have an impact. He summarized target delineation strategies, and he reminded the students that the CTV expansion has to be based on anatomy rather than geographic expansion. Two questions remain, whether elective nodal regions are more important in the NSCRT versus the definitive chemoradiation setting. In the definitive chemoradiation, failures tend to be more in-field and in the tumor rather than out of field, whereas in the neoadjuvant chemoradiation setting, the elective nodal regions become more important as the local control within field improves. And as Dr. Balu mentioned in his last talk, is that whether we should save the save nodal failures for salvage rather than expanding portals. And we've had an experience with a number of patients salvaging nodal failures in the superior mediastinal region with actually very good outcomes. And Dr. Balakrishna, summarized on the strategies and the questions in designing an optimal neoadjuvant strategy. He pointed out to variable practice in India due to practical issues, and he pointed out to the lower completion rates of chemotherapy in clinical practice in India. He pointed out to thrombocytopenia, but I'd like to add by saying that scheduling is one of the main issues why completion rates are low, because in the 5th week of chemoradiation of the 23 fractions with cross, you are left with only 3 days to fit in the last cycle of concurrent chemotherapy, and that's been a challenge in busy centers like ours. Default for surgery is an important issue that we do need to address in India, and based on Dr. Mukherjee's words on the practice in the UK, where a number of squamous cell carcinomas, especially the slightly older patients and slightly smaller tumors, are offered definitive chemoradiation, is a very interesting proposition. In terms of patient selection, I have to say that in our center, we do not look at the cross eligibility at all, and we offer chemoradiation to all our to all our operable patients, and we haven't had much toxicity to worry about so far. And he did mention studies like the PROTECT and ESOPEC, where more chemotherapy is being added to the neoadjuvant setting, and we look forward to the results of these studies. Thank you very much.
Thank you, Dr. Indranil, for the excellent summary of the talks. We had a fantastic session. We are honored to have with us Dr. Tapan Saikia, who is a senior medical oncologist at Prince Ali Khan Hospital and former professor of medical oncology at Tata Memorial Hospital. I'll request Dr. Tapan Saikia, sir, to give some closing remarks and conclude the session.
Thank you, Sayan. I really enjoyed all the talks and the interesting discussions, and finally, beautiful summary by Dr. Malik. At a personal level, I probably counsel. I emphasize the word counsel. About 10 to 15 cases of esophagus every month. That's a high volume. That's because I was born and brought up in Assam, and people still come to me every day. So I think what we talked about is about 15 to 20% of the all esophageal cancers we see in India. Still 80 to 85% of the cases are completely different matter in the real world. And we need to have answers for those cases as well. But having said that, it was a beautiful session. and enjoyed it. Thank you. Thank you, thank you organizers again. I learned a lot today.
Thank you, sir. Thank you very much for joining us. Now for the next session, would like to invite our chairpersons, Dr. Savita Arora, who is Associate Professor, Department of Radiotherapy and Oncology, Maulana Azad Medical College, Delhi. Dr. Surabhi Gupta, who is Associate Professor, Department of Radiation Oncology, SN Medical College, Agra. And Dr. Sonali Pingle, who is Consultant, Department of Radiation Oncology, Dinanath Mangeshkar Hospital, Pune.
Good evening, everyone. Good evening, everyone. Am I audible?
Yes, ma'am.
Yeah, it's my pleasure to invite Dr. Rashi Agrawal to moderate the next session on carcinoma of esophagus. Over to Dr. Rashi.
Yeah, thank you so much, ma'am. Thank you very much. So I think my screen is visible.
Yes, visible.
Yeah,
it's visible.
Yeah, thank you. So I am introducing my experts, Dr.
Can you make it full screen? Can you make it full screen, Rashi?
Yeah, I am doing that. Yeah, so my experts are Dr. Indu Bansal. She is Senior Radiation Oncologist and Director at Narayana Super Specialty Hospital, Gurgaon. Dr. Jaskaran Sethi. He is Senior Consultant in Radiation Oncology in Rajiv Gandhi Cancer Institute, Delhi. And Dr. Shyam Singh Bist. He is Senior Consultant at Medanta Hospital. And with us is Dr. Vivek Mangla. He is Surgical Oncologist, Senior Consultant at Max Hospital, Delhi. And Dr. Sajjan Rajpurohit, he is Medical Oncologist at our institute, that means Max Hospital, Delhi. So I am coming towards my first case. These cases had been asked in our survey also. So 80 years gentleman, he was diagnosed to have carcinoma esophagus, and the disease was starting from 30 centimeter. It was poorly differentiated squamous cell carcinoma. Performance status was good and without any comorbidity. In the whole body PET CT, the disease was of 5.7 centimeter in length, and the disease was in lymph node also, subcardial lymph node, and also the gastrohepatic lymph node. And metabolic active right adrenal lesion was there of 2.6 into 1.4 centimeter in size. So this is the case scenario in which the patient is having oligometastatic disease in carcinoma esophagus. So my first question to my panelist, Dr. Vivek, he is surgeon. Dr. Vivek, I want to ask you, what will be the intent of treatment? Dr. Vivek.
I think I take care of GI and HPV oncology, and when I look at esophagus cancer, or for that matter, even gastric cancer, intent of treatment in patient with oligo or extensive metastatic disease would essentially be palliative. Very, very rarely there is some retrospective evidence which says that in some patients it would benefit, but then largely we have to accept that these would be anecdotal experiences where our very, very selected patients have been taken up for definitive treatment or for curative treatment, but by and large the intent would be palliative.
Okay. And you are saying it will be palliative treatment.
Yes.
So my question, yeah, in 80 years with this disease, you are saying palliative treatment. So my question with Dr. Shyam. Dr. Shyam,
yes.
For palliation, would you like to do stenting, or would you think some curative treatment?
Rashi, in this case, this 80-year-old gentleman with oligometastasis and a good PS and a single deposit in the adrenal. So, like if we talk of whether it is a palliative or curative, we know it's a metastatic disease and palliative, but there is something called high palliation, or simply like if you are expecting a life expectancy of maybe less than 3 months or more. So according to this patient profile, I don't see he won't survive more less than 3 months. So life expectancy may be more than 3 months. So in this case, a stenting I will only go for those patients in which we see a very grade 3 or 4 dysphagia having a very short life expectancy. But in this case, I see it more. So I want, because we have seen a lot of cases also stenting, there are a lot of problems. Stent maybe for 3 to 4 months work well when the duration increases, even the severe complication in the stent rate increases drastically. So in this case, I would like to go rather than a stent, even if you go for a covered stent also. So there are different problems with the stent. I won't discuss all those problems. So I would like to go for a NJ placement, nasojejunal placement or nasogastric placement rather than a stenting, followed by other treatment modalities.
You are saying rightly, Dr. Shyam. So my next question to Dr. Indu. Will you plan radiation in this patient?
So Rashi, this patient is an 80-year-old gentleman, thankfully without any comorbidities, but this patient is an synchronous oligometastasis. This is not a metachronous metastasis. So synchronous metastatic patients are definitely do poorly, and patients with pulmonary mets may still do better, but a patient with adrenal deposit, I'm not expecting patient to do really very, very well, although it's an oligometastatic setting. But as Dr. Sham also rightly said, I'm not too keen for stenting, because middle 1/3 esophagus, whenever you put in a stent, there are very high chances of stent slipping down. So if this patient is ECOG 1, no comorbidities, then I think I would be happy to put in an NG tube if it is possible. This patient is able to take liquids as mentioned in the slides. So maybe palliative chemotherapy would be a low dose chemotherapy, maybe some weekly protocol. I would be happy. If the patient is not willing for any chemotherapy, then definitely palliative radiotherapy I would consider rather than giving a stent, because stent we usually prefer if the patient has life expectancy of less than 3 months, but he's a fit gentleman, so I would not be too happy to put in a stent right away.
Okay. So ma'am, you are suggesting for chemo first, not for radiation.
No, because it's oligometastatic setting, it's a synchronous met. So if the patient is not willing or not fit, then definitely we can offer palliative chemotherapy, palliative radiation.
Okay. So my question to our medical oncologist, Dr. Sajjan Purohit. Dr. Sajjan, which type of chemo or targeted therapy would you like to start?
Dr. Rashi, I think the most preferred drug will be an oral drug. Most probably capecitabine will be my preferred choice. Because with a gentleman who is 80 years old, I would like to give them oral drug, because that will probably have good quality of life for this patient. I think, and if the patient's tolerance is poor, then I can also shift on weekly nab-paclitaxel if the drug choice is not good on the first line.
So this is squamous.
Yeah, this is squamous.
Yeah, it's squamous. Yeah.
So Dr. Jaskaran, now the final question to you. How will you sequence this treatment? Would you start radiation? Would you start chemo? How will you do? Dr. Jaskaran.
Am I audible?
Yeah, you are audible, sir.
Yeah, I think personally, if you ask me for my opinion, I would like to go in as suggested by Dr. Bisht, to go in with palliative RT, because at 80 years, what would be the tolerability of the patient with oral capecitabine or nab-paclitaxel is even more questionable than tolerating a high palliation dose of radiation. And here we are not looking at a very short survival, so naturally stenting would be the last to be offered.
That's great. So we all are starting with actually palliative radiotherapy. So my question and next question, this patient is of 80 years. If this patient would have been of 60 years, Dr. Vivek, the intent of treatment, would you like to have high palliation or would you like to change something?
I think the intent would still be palliative. Although at the same time, I don't know, just a word on stents. I think we are maligning the stents too much here. At the end of the day, they provide excellent dysphagia. That will probably be the quickest response in dysphagia. Once you have metastatic disease and you're not expecting a great survival in the patient, I think all the more reason to probably consider a stent and then add RT, because otherwise the patient would be hanging around with a rice tube. And what would we be palliating? We would not be palliating dysphagia. We would be able to provide some nutritional support to the patient till radiation have its effect. So it may not be too bad an idea. And second thing which I would like to add here is that when you have nowadays there are retrievable esophageal stents also available. So in case there is too much of a concern about stent slippage in this patient, who's got a high-grade dysphagia, barely able to take liquids, there's very likely that there is going to be a nice stenosing growth there. And especially if this patient is not being considered for radiotherapy, then all the more reason that keeping a SEMS there is going to palliate the dysphagia. Putting in a rice tube is not going to palliate dysphagia. It is just going to get the nutrition into the patient. In this, changing the scenario to 60 years, by and large, I think the intent would still remain palliative.
So, Dr. Indu, would you like to comment something at 60 years and your opinion regarding these stents, as Dr. Vivek has mentioned?
No, I would be happy to give palliative RT rather than stent. I would be more than happy to give, I'm talking about the earlier case. So rather than putting a stent, I would be more willing to give 30 grain 10 fractions or something like that. So stent, I would not keep as the first option for this patient. No.
So at 60 years, if any of you, your previous opinion will vary at 80 years and at 60 years. Dr. Jaskaran, Dr. Shyam, your previous, Dr. Sajjan, your opinion of treatment?
Maybe at 60 years, we can go more drastically. We can increase the dose of radiation, but definitely stent, I will not like to go for stent, because we have seen a couple of patients with perforation, bleedings, slippage, pain, and sense of even the dysphagia will relieve, but there is sense of something like sticking in the throat. So for stent, it is clear in our mind that if there's very short life expectancy, we would like to go otherwise, because radiation will give a very good relief in the dysphagia.
So retrosternal discomfort is also more with a stent, and chances
Yes.
of stent overgrowth of the tumor, we see that very commonly. So stent is not a very good option.
I think we all are agree, Dr. Jaskaran, you also agree.
I think in this patient, if the patient is 60 years old, there is a point of going with a little more aggressive chemotherapy, and then maybe attempting palliative radiation, or
Dr.
maybe.
Ashita, I'd like to concur with Dr. Vivek Mangla, because we have had a lot of patients of esophagus, and my experience with stents has been really good. So stenting, I don't think is that bad an idea. I know if you're considering with palliative RT, then probably there are some concerns. But usually when patients are not being considered for RT, we always prefer to go for stents, and we have now stents which can be easily changed, or once the patient has recovery with chemotherapy, they can be removed also. So I would concur with Dr. Vivek Mangla on using stents in esophagus, especially mid-esophagus.
So I think I have created the base, and Dr. Pablo will cover this talk on this, what to do when there is metastatic disease, how to do that. I am coming over second case. And this second case is 62 years gentleman having good performance status without any comorbidity. He was diagnosed as carcinoma lower esophagus involving G junction. That means Sievert 2 disease. And but he was having a lymph node at gastrohepatic space of around a huge lymph node of 6 into 4 into 4 centimeter size. Biopsy was poorly differentiated adenocarcinoma. You can see in the slide the huge disease with a lymph node. This was gastrohepatic lymph node. And my question to start with Dr. Vivek. In this case, what will you think, curative or palliative treatment?
I think in this patient, if I see, essentially the disease is loco-regional. As far as I see this disease, I don't see any evidence of metastasis within the images that we have been shown. The performance status of the patient probably is also good. Now, at this point in time, we may be proven wrong, but I would generally start with this patient with a curative intent treatment. At least at this point in time, the intent should be curative. In some certain percentage of patient, I think what is the probability of patient having a response? A significant proportion of patients are going to respond. By and large, in these patients are I think Sajjan is also going to comment on that, would be to give neoadjuvant chemotherapy rather than chemoradiotherapy. And probably that's where we would see a significant response rate. In earlier times when we were using ECF, they were a little lesser with float, which would usually be the standard of care in this patient. Now with adenocarcinoma, I think we expect a very, very good clinical response in these patients. And probably the intent, as far as I am concerned, would be curative, at least at this point in time.
Yeah, you have said rightly. So my question to Dr. Sajjan, would you start chemotherapy, or Dr. Indu, would you start radiotherapy?
Dr. Rashi, I think there's going to be really debate with respect to whether we start chemotherapy versus chemoradiotherapy. But in this patient, I'll be happier to start on chemotherapy with slot regimen and see whether this patient responds nicely to chemotherapy. If the response is good, then probably there's more chance of this patient getting benefit from surgery. But anybody who, if the radiation oncologists feel that the radiation field will be good and the response can be good, then obviously the other option is also good.
So Dr. Sajjan, which chemo will be resumed? In short, please in short.
Flot regimen, 4 cycles weekly.
Dr. Shyam, in radiotherapy, what will be your dose prescription?
Like if the surgeon wants to operate, if we are giving with a new adjuvant intent, then I would like to go with the cross or slightly modified 45 in 25.
Okay, that means Dr. Sajjan is saying will start from new adjuvant chemo, and you are saying if surgeon is comfortable, then you will start from concurrent RTCT. Okay, Dr. Daskaran, what is your take?
I think I would 41.4 or maybe 45 for such a big node to regress appreciably. I'm not very sure. So I would like the neoadjuvant chemotherapy to come in first, and
Okay.
then basically irradiate a lesser volume
Yeah.
at a later stage.
Yeah, Dr. Indu, do you agree with Dr. Jaskaran?
So routinely, like even for adenocarcinomas, I am happy to do NACT-RT. But of course, these cases are best discussed in a tumor board meeting. And my surgeon has to be comfortable to operate it, because with a 5.6 centimeter node, this is slightly a very, very tricky situation, because then the area that would be treated would be little large. So in such situation, this particular case, I'm little tempted to give chemotherapy first and then give response, because the tumor nodal size is very big. This is 5.6 centimeter.
So, Dr. Indu, you for this patient, he received 6 cycles of Folfox, and after that he received the chemoradiotherapy, 54.
Why 6 cycles? Why not 3? Why was not assessed after 3 cycles?
Actually, he was assessed. He was unresectable. So 3 more cycles were given so that patient can be resectable. But after that, surgery was not possible. Then RTCT was given, and it was done 3 years back. And he was on regular follow-up, and there was a metabolic lesion. And after disease-free interval of 2 years, 1 month, ECOG, his score was performance status was good, and his PET CT in April 2020 showed that size of lesion and SUV both have started increasing. And again, biopsy was done. It was adenocarcinoma. Uh, so what next? Dr. The case was unresectable. Now after 2 years and 1 month DFI. Dr. Vivek, your opinion?
I think this is a problematic patient. You've given chemorad, the time duration has been long. You have got a big bulky residual disease or recurrent disease, whatever you want to call it. And I think as far as we are concerned, surgery in this patient would be very, very difficult and very, very tricky. And I would be extremely cautious. I would rather have Sajjan or Dr. Rashi consider something more in this patient rather than me going in at this point in time, for sure. I don't know. I have 2 questions to ask if Dr. Rashi will allow me some time, but I'll let this discussion finish and then I'll ask those 2 questions.
Sure. Doctors, you can put your question in chat box also.
Yeah, I'll do that.
Yeah, Dr. Sajjan.
Yeah, so at this point in time, I think my intent will be really palliative, but yes, we could have a multidisciplinary meeting and we could discuss the role of re-radiation. But if you ask my opinion will be palliative chemotherapy.
Dr. Indu ma'am, re-RT.
So this patient has lower 1/3 esophagus growth also, and not just the node.
Yes, both diseases.
Yeah, so and node is still big, and patient has received 54 gray, although the disease-free interval is more than 2 years. So it's a good disease-free interval. I'm little tempted for SBRT also in this patient, but this has to be discussed. Maybe 2-3 cycles of chemotherapy and reassess, and SBRT I would consider in this particular patient, definitely.
Yeah, actually surgery was attempted, but patient was inoperable, and so many types of chemotherapy were given. But what happened? The disease was in progression. So that's why we asked for re-radiation. Dr. Jaskaran, what is your opinion about re-radiation? Dr. Indu is thinking about re-radiation.
Well, the first thing is that the intent is palliative. So, what are we going to irradiate? Number one. Number two, it's very, you've given a dose of 54 gray in the first instance. Very important to see the OAR doses received by the patient at that time and the allowances. We know that if you're giving a re-RT at conventional fractionations, then any dose less than 40 or 45 gray actually doesn't make a lot of sense. SBRT or maybe a re-RT using proton therapy.
Okay.
Yes, but
Yeah.
I am not very sure about going in with re-RT because what is the intent? Intent still remains palliative. So is he
You are
having any
right.
pain that we are going to decrease? Or is there any other symptom? Why not just palliative RT again to this patient?
Yeah. You are very right. So my question to Dr. Syam. Dr. Syam, what will be your opinion? This is my last question to you.
In this case, I would like before attempting the re-RT, I would like to go for a chemotherapy, and after chemotherapy, we'll see the response. And based on the
Dr. Syam, we already have given so many chemos. Flot, then after that, paclitacarbo. Disease was in progression.
okay, so the re-RT can be definitely thought of. Re-RT has been tried many times in esophagus also, and even a dose of I think at least 45 to 50 gray would be sufficient. Had it been only a nodal, I would have gone for a SBRT for the node, but SBRT for the G junction.
Yes, I agree, Dr.
Yeah, you are. Thank you so much. Actually, this panel discussion was to create platform for further talks. Thank you so much. We have created a platform for our further talks on re-radiation and what should we do when there is a need of dysphagia palliation. Thank you so much, panelists. Thank you so much.
Dr. Rashi, am I allowed to ask my questions?
You can ask.
Just two quick questions. Now, this question is for the radiation oncologists on the board. One is, if you replace the adeno with a squamous in this patient with a CVR2, how would you change things? Like, you would still consider chemotherapy, neoadjuvant chemotherapy or neoadjuvant chemoradiation? And the second question is, when we are talking about CVR2, I'm a surgeon. My concerns are, you give radiation, there is radiation injury to the stomach, colon is a potential conduit. This patient might be headed for a esophagogastrectomy. And we have had situations wherein neoadjuvant chemoradiotherapy has been given, and subsequently at surgery, you are really struggling to decide how to go ahead and do a safe reconstruction in these patients. So how do you ensure that the colon, the transverse colon, which is a possible conduit, jejunum, which is potential reconstruction after a total gastrectomy, maybe with a distal esophagectomy, how do you go about ensuring that these organs are preserved? In a classical CVR3, it is very standard. You just irradiate the upper part of the stomach and the rest of the stomach would be safe for pulling up.
In these cases, like there are definite dose volume guidelines, and most cases of the complications, especially the leak, it is most related to the dose to the fundal area. Because if you are trying to do an anastomosis in the neck, and or if you are doing in this, I think possibly you would try to do an anastomosis somewhere in the middle part, towards the level of esophagus. So dose to the fundus has been correlated with the risk of complication. So we'd like to try to limit the dose to the fundus area. We'll try to make it more homogeneous rather than having a hotspot in those areas. And also we'll try to keep the restrict the mean doses to the lungs. So I think that will further reduce the complications for a surgery.
Okay, and obviously when you have a tumor which is coming down, like CVR2 going on to like something which is coming down along, especially in this patient, you have a tumor which is coming along the lesser curve, and somebody said they would be happy giving neoadjuvant. I think Dr. Indu said that she would be happy giving neoadjuvant chemoradiotherapy in this patient. I think there would be a lot of concerns, but somewhere she agreed to saying that her surgeon has to be comfortable. I think that's an extremely important point there, that it has to be a tumor board decision, and the surgeon on board, being on board on this, that yes, this is how our next step surgery is going to be planned when we are considering in the neoadjuvant setting. Thank you, Dr. Rashi.
Thank you. Thank you. Over to chairpersons.
A very good evening. I'm audible, Dr. Rashi?
Yeah, audible, ma'am, audible.
Yeah, a very good evening to all of you. It's my pleasure to invite our eminent speaker, Dr. Edgar Ben Joseph, for this talk on very debatable topic, that is dose escalation carcinoma esophagus. Is the jury out? Photon versus proton. Dr. Edgar Ben Joseph is Vice Chair, Translation Research, Radiation Oncology, Penn Medicine, USA. Dr. Edgar, now it is over to you.
You need to unmute. Dr. Edgar, you need to unmute.
Yes. Yeah. Okay. Can you hear me now?
Yeah.
Yes.
Go ahead.
I was just saying thank you very much to the organizing committee for inviting me to give this talk. It's a pleasure. And good evening, everybody. Let me see if I could share my screen here. You can share all panelists. Yeah. Okay. That's. Can you see my screen?
Yes, we can. Thank you.
Okay. Okay, so I was asked to give a talk today about proton therapy for esophageal cancer, and also to discuss radiation dose escalation. And by listening to the prior few talks, I understand that this has been discussed a bit along earlier today, but I'll give you my take on that as well. Okay, first I'd like to give thanks to Dr. John Plastaras, who at the University of Pennsylvania in my radiation oncology department, he is actually the person who is heading most esophageal cancer trials and clinical practice. We all do in the GI oncology team, but he is the one that leads that. And he provided me with some slides that I've then modified and added my own. But I want to acknowledge his part in this. So as many of the speakers rather easy to give and tolerate, and it doubled survival from 24 to 49 months median survival. At least in radiation oncology at the University of Pennsylvania, and I know many other cancer centers across the United States, it has become the standard of care for neoadjuvant therapy cases. And within that context, we use proton therapy in all patients who could be approved by insurance for proton therapy. And the rationale is also very straightforward. I mean, what you see there is 3 plans, just representations of 3-dimensional conformal radiotherapy on the left, IMRT in the middle, and pencil beam therapy, proton therapy on the right. And what's striking is that you increase conformality with IMRT, but it comes at the expense of low to intermediate dose to the lung and heart. And as you go to proton therapy, that is reduced and you get both conformality and very low entrance and exit dose through the lung and heart. So I didn't put here those volume histograms, but I did provide some example cases at the end. I'm not going to review the example cases, but you can take a look at them. The difference in those volume histograms are striking. It's not a subtle thing that you have to squint to see. They're really striking in terms of dose to heart and lung. I'll show some data from MD Anderson mostly showing that the dose to the lungs may affect pulmonary morbidity and complications after surgery. And the dose to the heart is associated strongly with cardiac mortality mostly in the unresectable patients. So sparing heart and lung from radiation dose is the main rationale for proton therapy. This is the data from Steve Lean at MD Anderson, published in 2012. They've looked at 600 and some patients retrospectively, and they show that IMRT had better survival and better local control as compared to 3D conformal therapy. When they tried to analyze the source for those differences in survival, it was mostly cardiac toxicity. You can see that in the right-hand top panel. Cardiac toxicity was significantly higher in the 3D versus the IMLT planned patients. So there were, what you see in the lower panel is unknown causes of death, which were a significant number. So it's a retrospective review, and not all causes of death are actually established with certainty. So it has some of the weaknesses of retrospective analysis. Next, they look at the more recent experience with proton therapy versus IMLT. So the idea was that if IMLT is sparing and proton beam therapy would be even more sparing, maybe there are gains there clinically discerned. I would say that the majority of these patients were not treated with pencil beam scanning, which is which allows more focused delivery of radiation therapy. It was done probably just with older methods of proton therapy. But even with that, at least retrospectively, they showed a significant difference in overall survival, progression-free survival, and local control. And I have to say, I don't know that I would believe all of that. You have to be a bit skeptical. We'll talk about the caveats to those sort of, not just a retrospective review. One of the most important things in a retrospective review like that is the stage migration. So as more and more patients are staged by PET, you have better patient selected for therapy, for radiotherapy in recent years. And clearly proton therapy was more recent than IMLT. And it's the same for the other comparison of IMLT to 3D. So there are some things that you cannot really account completely for in these retrospective reviews. But be it as it may, they did show these differences, and then they went on to conduct a phase 2 trial. And this is a famous publication in JCO from 2020. Again, Steve Lean in this phase 2 study comparing protons to IMLT shows that survival and disease-free survival are actually not different, but what was different was the toxicity. And they came up with an index that measured the overall impact of toxicity, which they call the total toxicity burden, and that was significantly improved with protons. This is, again, mostly passive scattering protons. This is not the most recent technology in proton therapy. You could do better with pencil beam scanning. Here is the data from that phase 2 study. The total toxicity burden was 2.3 times higher for IMLT, and the post-operative complications were 7.6 times higher for IMLT. So I think, people have criticized him for coming up with these indices as endpoints in the trial, but I think he actually did the smart thing. I mean, it would be a little bit far-fetched to think that in a small trial, 50 to 100 patients, you can discern survival differences or even disease-free survival differences when you're not really impacting anti-cancer therapy. What you're impacting is toxicity. So making an index of toxicity one of the main endpoints, I think, was very smart, and it did turn out to make this a positive trial. At any rate, this concept is now being tested in a NRG, previously RTOG trial. It's a phase 3 randomized trial looking at protons versus intensity modulated radiotherapy. Again, the objectives are not only to look at overall survival, to see that it's either better or non-inferior to IMRT. But importantly, there's also an endpoint that looks at grade 3 cardiopulmonary toxicity with proton versus IMRT. And I think that likely, even in a larger trial like this, it's going to show that survival and disease-free survival are probably not very different. But toxicity probably is improved with protons, and even if there's a reduction in some perioperative deaths in patients with protons, or in the long run, reduction in cardiac death over the years, it might not be enough to actually make, even in a phase 3 study, an overall survival benefit. But time will tell. The design of this trial is pretty straightforward. I mean, there's a registration, then there's a randomization. They account for all the different factors that could make a difference. Adeno versus squamous, obviously stage. They allow both resectable and unresectable patients on this trial, and for factors like induction chemotherapy or not. And then it's the carbotaxol regimen, and in following 4 to 8 weeks after radiotherapy with surgery in patients who are considered resectable up front. Okay, so I am going to switch gear now to dose escalation. And dose escalation is, I think, for radiation oncologists, it sort of makes sense, right? And we know that radiotherapy can kill any cell. It's just a matter of the dose that you are delivering. So, but it is also a fairly simplistic way of thinking about this. And I'll tell you why I think that in a minute. So dose escalation in esophageal cancer is not new, right? The concept has been around for at least 2 decades. And the first trial that addressed this was Bruce Minsky's trial, which you probably are very familiar with. It was a trial that intended to enroll 200 and some patients, randomizing them to 50 gray versus 64.8 gray. And the chemo regimen was platinum 5FU. The volumes were fairly standard volumes. The radiotherapy planning was fairly rudimentary. It was 3D and 2D at that time. And it is famous because the trial would stop very early for analysis of mortality. There was early mortality. And people were jumping to conclude that early mortality was related to the radiation dose. Only turned out that the majority of these deaths, 7 out of 11, occurred before they reached 50 gray. So after some modifications, the trial was resumed, but eventually showed that there was no difference in survival. There was no difference in local control. But the survival was simply not promising. In fact, you see that sort of nominally the survival in the high dose arm was actually lower, although statistically not significantly lower than the standard arm. And then people had said, well, you have to remove those patients who died early because they would not contribute to the benefit. So even when you remove that, there was no shred of a suggestion that there's any benefit in the high dose arm. So, and that sort of was our thinking for a good number of years. Then, again, a study from MD Anderson, maybe because Bruce Minsky had moved to MD Anderson after that, published again in recently, 2019 in JAMA Oncology, a phase 1/2 trial looking at an integrated boost, simultaneous integrated boost, again, escalating the radiation dose, and showing that, at least in this trial, the local relapse rate was actually cut in half, hazard ratio of 0.49 compared to historical controls. and the median overall survival was improved by 30-some%, with a hazard ratio of 0.66, both statistically significant. Well tolerated with no grade 4-5 toxicity. I have to say, we used to joke at my prior institution at the University of Michigan that everything that comes out from MD Anderson is sort of positive and rosy. And this is just one more example of that. You have to take it all with a grain of salt. There's lots of caveats to this data. It's a single institution tertiary cancer. They surely have a lot of experience in treating cancer. They surely have the top patients anywhere in the world with the best resources. All of these patients were PET planned. By the way, hidden in the prior Lin study from 2012, they showed clearly that PET planning and PET staging was strongly associated, significantly statistically associated with survival. So all these patients are PET planned and PET staged. 85% of these are IMLT and 15 are actually proton therapy patients. So you have, extreme selection factors in favor of these patients. It's no wonder that when you take this thing to a larger national or international setting, these concepts fall apart. Currently, as other speakers have said, there are 3 trials that are assessing radiation dose escalation. One of them is the French trial. It's 66 versus 50 gray with FOLFOX. The other one is in the UK. It's a chemo trial, a carbotaxol versus cis-capecitabine, but there's a second randomization within that trial of 50 versus 60 gray in 25 fractions. And then the Art Deco trial that was just recently reported in an abstract form a few months ago, 50 versus 61. And I'd like to review the results that have been reported by the Netherlands group. So this trial have administered the cross-trial chemo regimens and randomized the radiation to 50 gray, 50.14 gray, and 1.8 gray fraction, versus 61.6 by, again, an integrated simultaneous boost of 0.4 gray per fraction. And the endpoints were the local progression-free survival, 260 patients, median follow-up 45 months. And as you can see at the bottom, there was absolutely no difference in overall survival or local progression-free survival. And importantly, the grade 4-5 toxicities in the high-dose arm were high, particularly death related to toxicity. You can see that 4%, as you'd expect in the standard cross regimen, versus 10%, so doubling of the death rate from toxicity in this trial. So it just goes to show that what might work in a small tertiary center specializing in cancer patients might not work in a larger national or international group. And I think that high-dose radiotherapy is not ready for the larger audiences. I also want to point out that these concepts of dose escalation were tested in patients with unresectable disease. And in my opinion, this is not a very good population to test this concept. If there's any truth in this, you are actually shooting yourself in the foot by limiting your ability to show a difference. And the reason is in this sort of curves that I sort of jotted on this slide, as the stage increases from early stage to late stage, the probability of death from local control increases, but so does the probability of death from distant metastasis. In order for us to be able to show a difference in survival related to local control, you have to impact local control significantly. But then you have distant metastasis death as a competing factor. And when it exceeds, the death rates exceeds, as you can see on the right hand of the slide, exceeds the death rate from local failures, your chances of actually demonstrating any difference related to local control are diminishing very quickly. So in my mind, the proper population to test this concept is in the early stage resectable patients that go for neoadjuvant therapy followed by surgery. And this is exactly what we are doing at the University of Pennsylvania. The principal investigator on this trial is John Plastaras, that I mentioned before. And we take patients that would be eligible for the cross trial, and we then escalate the radiation dose from what we would consider standard dose, which is 50 gray. We are now up to 60 gray, all in 25 fractions. So it's 60 gray at 2.4 gray fractions. And so far, we have seen some minimal toxicity, but not significant, nothing that should impact our dose escalation further. And the trial is ongoing. We do this with proton therapy. So I think that, as I said before, the proton therapy allows for a safer dose escalation by virtue of reducing lung and heart dose. Before I end, I just want to go over a number of important considerations for proton therapy. I'm not going to dwell on that too long. It's not the main topic of this presentation, but things that anyone treating with proton therapy should be cognizant of. One, for proton therapy, motion management is extremely important. You have motion at the level of the diaphragm, and the proton dose distribution is very sensitive to anything that is in the path of the beam. So if more of the beam goes through lung, where you intended it to go through solid tissue, you would end up with those in very unexpected places. So the planning needs to be robust. We use posterior beams because there's less anatomical variation with breathing as the beam comes from the back. What you see there would be a fairly common beam arrangement that we use. Another common beam arrangement would be a posterior and a left posterior oblique. It's not only robust from a anatomical variation point of view, but also it reduces quite substantially the dose to the heart and lung. You can see where the blue line stops is where the radiation dose actually stops. So you can see there's a lot of sparing of the heart. We use pencil beam scanning. You have to account for the range uncertainty. We don't use robust optimization, but you could use that. And you have to use IGLT with every fraction to make sure that the dose actually goes where you want it to go. So in conclusions, protons are clearly superior to intensity modulated radiotherapy from a dosimetric point of view. And the advantages in sparing heart and lung. Protons are likely superior clinically in pre-op patients. It could reduce pulmonary toxicity and post-op complication. It could actually reduce cardiac toxicity, at least by retrospective data. And we have phase 3 trial that is ongoing that is going to look at this. Dose escalation, in my mind, is not safe, neither beneficial in a community or in a national setting, demonstrated very clearly by the Art Deco trial. Possibly, it's safe and effective in specialized centers. Protons could allow safer dose escalation in this disease. And I think that it would have been better to do these trials and test this concept in pre-op patients rather than in unresectable patients. That's all I have.
Thank you, Dr. Edgar, for an excellent talk. Now, I would like to invite our discussion team, Dr. Deepti Sharma, Consultant ILBS Delhi, Dr. Richa Chauhan, Consultant Mahavir Cancer Sansthan, Patna, Dr. Anil Goyal, Professor and Head, GMC Baroda. Kindly proceed for the discussion.
Very excellent talk, Dr. Joseph. And if we see chronically the data, it is established from intergroup 1 to 3 that if you give P plus F plus 64.8 gray versus 50.4 gray into P plus F, the median survival and 2-year survival is similar. right? And slightly better with the 50.4 gray. But the criticism was that the older machines were used. And then National Cancer Data said they did a study on 6,854 patients. And they also used, compared 50.4 plus RT, CT along with the 60 gray. And again, there was no difference in overall survival. And the data was consistent with intergroup 1, 2, 3. So that means all the guidelines accepted that there is no need to go beyond 50.4 gray in locally advanced esophageal cancer. But if you study the intergroup 1, 2, 3 trial, the most of the recurrences or residual disease in locally advanced cases were in the GTV. 90% were in the GTV. So Chen et al. Basically formulated why not to use, say, SIB technology and use the PET-CT for the tumor delineation. And ultimately, the gross tumor in the nodes, with the 5 millimeter margin, were given 66 gray, and the rest of the subclinical disease was given 50.4 gray. And excellent, although only 46 patients, but excellent 1 year local control 85% versus 70%. So that basically initiated the enthusiasm in the dose escalation. And ultimately, they also incorporated intensive modality proton therapy, in which say dose escalation was divided, and it was better than IMRT in the sense that the residual disease or local regional recurrence was, say, half than with the IMRT. The only thing is that when you're using intensive modality proton therapy is very sensitive to the interfraction and intrafraction movements. For example, intrafraction movement may be due to the interplay effect between the moving target and the scanning beam. So, and the interfraction may be due to the tumor changes, stomach distension, or movement setup variability. So how do you decide how to use the single field optimization or multiple field optimization? How to use the beam angles which are least affected by the motion? Like you said, the robust plan optimization. So how usually you go for that? This is the only question.
So we typically use either in the trial that we are running. So if I have to say, the interplay effect could be mitigated by many ways. You could either use SDX, which is a breath hold device, and treat patients at breath hold. We don't do that with protons. Our method that is much more preferred is the compression belt. Compression belt not only reduces motion, but also reduces the interplay effect. And we have shown that very nicely in a paper that we did in medical physics maybe 4 or 5 years ago. The first author on that is Lean. We also show that when you give many fractions, so first the compression belt reduces motion to maybe 5 millimeters at the most. That tends to reduce the interplay effect as well, quite dramatically. But then you have repainting, right? So another method to deal with this is to take every fraction and give it, instead of in one single administration, say breaking into 2 or 3 administrations. So you paint and you repaint and you repaint again, and then you finish the fraction. You actually don't need to do that when you have multiple fractions. And we showed that once you are above 5 fractions, the repainting effect essentially of the 25 fractions plus the compression belt brings you into a less than 3% dose variation. So I think that has a technical solution that is very simple.
Yeah, thank you. But the only thing is that with IMPT, actually the penumbra again is a basically deciding factor, because if you see lower sigma with respect to the higher sigma, with the higher sigma, then again penumbra comes into the action, and the critical organs nearby, it has to be tested like in the more randomized trials, how it is better than the IMRT technique.
Yeah, no, I agree. I mean, all of these are sort of concepts that that are not completely proven. They are very complex concepts. I have to say, we have treated many patients off trial with protons and with PBS, with forward planning, with sort of backwards planning and inverse planning. And I don't think that we have any sort of complications that stood out as, so we do not have any concerns using these technologies to treat these patients off trial. the trial element is the dose escalation. So surely I would not treat someone off trial to 60 Gray. Off trial, our radiation dose is 50.4. It's really the cross trial regimen. But on trial, we go to a much higher radiation dose.
And Chen et al. Has also modified the CTV, GTV to CTV margin. It is 2 centimeter below rather than.
That is not particularly modified. I think we stick with the standard sort of recommendation for volume, but we just up the radiation dose.
Thank you, sir, so much, sir.
So thank you, Dr. Edgar, for a very informative talk. Yeah, I do agree there are contradicting data on dose escalation, mainly because of the toxicity concern. But then I have to say that if the problem is local, the solutions should be local. So I mean to say, can we go for a selective dose escalation? I mean, can we stratify our patients before starting chemoradiation based on maybe the grade of the disease, the histology, or the size of the node? Because we all know that if it's a 1.5 centimeter nodal disease, a single node, and another patient are having multiple nodes up to the size of 3 to 4 centimeter, they are not going to respond equally to the same dose of chemoradiation. So my take is that because I mean, taking into account the toxicity concern, can we go for a selective dose escalation with a careful selection of patients?
I think you, in principle, you're right. I mean, we know that the dose of radiation needs to be sort of proportional and appropriate for the volume of cancer that we treat. I mean, it's a age-old, concept in radiation oncology. So you're absolutely right about that. Whether we are actually ready to do this in clinical practice, I don't know. In a clinical trial, I think once you sort of show that the concept actually works, you could modify that, and in a second phase of trials, in a more advanced trial, then test those more nuanced sort of variations to the concept of dose escalation. We have not done that. We look at this phase. It's a phase 1 that we're actually running. It's a dose escalation. So we, like in any phase 1, we take all comers and we. But I have to say that as we have now reached a very high radiation dose of 2.4 Gray, it gives us a bit pause. And to your point, we have skipped the opportunity to put some of these patients on the trial who had relatively small cancers. We thought that the risk would be increasing as we increase the dose. And maybe the risk would be too high for the potential benefit that these patients derive from. So we have had a few patients in which we looked at this and said, oh no, this patient probably should not go on this trial. And we try and pick the patients that are really the very, very high risk patients for this trial. Yeah, I think you're absolutely right in principle.
In the current PNN staging for esophagus, they don't consider the bulk of the disease. But when we go to the radiobiological concept, the BED, that is directly proportional to the bulk. So
yeah, no, it's a deficiency of the staging system, and maybe also a problem with prior methods of how you assess volume. A lot of the staging is based, trying to make it simple for clinicians, and even today, I don't think that when you get a diagnostic PET or CT, you can actually tell the volume with like in 3D. In radiation oncology, we are sort of lucky. I mean, we've had this for a long time, but you cannot read it off simply on a diagnostic scan. You have to just guess.
Okay, so one last question. Nowadays, we are routinely using PET-CT. So can we incorporate the SUV value for a planned dose heterogeneity, a dose escalation to?
That's a different concept, and I think it's completely experimental. I think that the SUV might have to do with the aggressiveness of the cancer, but not necessarily with the sensitivity to chemoradiotherapy. So I don't know the answer to that. I think it's something that one could study, but you could certainly tailor your fields based on what you see on the PET. We use that, but we use that anatomically, not the actual SUV. Just as everybody else, I think, in the field does this, we look at the side that is FDG avid, and then we include anatomically that area in the radiation field, but not to guide the radiation dose escalation.
Thank you so much.
Dr. Deepthi, you need to unmute yourself. Dr. Deepthi, you need to unmute.
Hello. Yeah, sir, is there any role of interim PET scan? After, like, if we complete 50 gray in 25 fraction, then we can get an interim PET scan, and accordingly we can dose train the tumor, like up to 60 gray or 66 gray.
So again, this is experimental. There's data, a lot of data on guiding your chemotherapy regimen based on PET. That's the sort of data that came from the CLGB trials and from the group in Munich. But there's not much data on guiding radiation dose. And I know that at least at the University of Michigan, for instance, they were actually running trials of trying to guide the radiation dose and based on interim PET response. Again, I think it's experimental at this point. There's no data to suggest that you can take it into the clinic.
Thank you, sir.
Thank you so much, Dr. Edgar, for excellent talk, and thank you, discussant, for interactive session. Thank you so much. Now we will move on the next session. I would like to invite Dr. Pablo Munoz Subeniger. He is Assistant Professor, Radiation Oncology, Pontifical Catholic University of Chile. He will talk on the comparison of modalities of dysphagia as a palliation. Dr. Pablo, over to you.
Can you see my slide?
Yes, sir. Yes, sir. It's visible.
You can see.
Okay, great. Thank you. I'd like to thank the organizers of this meeting for inviting me to be part of this fantastic GI Cancer Congress and the opportunity of meeting some very good friends, Dr. Misra, Dr. Ashwafi, Dr. Tibdewal. And I've been given the opportunity to discuss on how to palliate dysphagia in metastatic esophageal carcinoma. And we already had a very interesting and controversial tumor board. And I hope that during the next 15 minutes, I'll provide some food for thought for further discussion. This is my conflict of interest. So during this session, I'd like to define the main malignant dysphagia treatment modalities. We'll discuss some randomized controlled trials on these different modalities and emphasize the need for multidisciplinary care for malignant dysphagia. And it's important to discuss about dysphagia, mainly because it's a multidimensional experience. So it doesn't mean only that our patients have a diminished oral intake, but it also compromises their overall health, their ability to seek for help, and it has a quite dramatic emotional and social impact. And do remember that patients with a metastatic disease and any patient with esophageal cancer who is not eligible for curative treatment has a median overall survival no longer than 9 months. And there are many different ways to approach malignant dysphagia. However, there's still a lack of evidence on what's the best way to do that. So during this session, we'll discuss 3 main treatment modalities, which are stents, external beam radiotherapy, and brachytherapy. So there are so many options, but we don't know how to proceed. And a few words on stents. We already touched some of these concepts during the multidisciplinary tumor board, but do remember that there's a wide array of different stents with specific advantages and disadvantages for each of them. And there's no specific type of stent which is superior in all aspects. However, nowadays, the self-expanding metal stents are the standard of care, and mostly partially covered stents are used worldwide, mainly due to their lower risk of tumoral tissue ingrowth. And as Dr. Shyam mentioned during tumor board, they do provide an immediate dysphagia relief, but with a median time to deterioration around no longer than 10 to 12 weeks. On the other hand, intraluminal brachytherapy delivers high radiation doses to esophageal tumors with minimal exposure to organs at risk. And it's quite convenient regarding that it minimizes treatment uncertainty. You can use it in either 1 or 2 fractions. And there are just a few contraindications for using intraluminal brachytherapy, such as tracheal or bronchial involvement, cervical location, or stenosis that hasn't been bypassed. Intraluminal brachytherapy is actually quite efficient. We know that from a systematic review that analyzed 6 studies published in 2017 with a dysphagia-free survival of actually 87% at 1 month. However, the dysphagia-free survival went down to 47% at 6 months. And you do need to take into account that 28% of patients needed 1 or more treatment due to relapse or complications, and also that there can be severe adverse events related to intraluminal brachytherapy, particularly stenosis or fistula. The CIRREC trial conducted in the Netherlands compared stent placement against brachytherapy with 12 gray in 1 fraction, having a primary endpoint of dysphagia relief and focusing on patients with metastatic esophageal cancers or GE junction tumors with that already had dysphagia, and it excluded patients with tumors longer than 12 centimeter, within 3 centimeter of the upper esophageal of the upper esophageal union, deep ulceration or fistula, airway involvement, or previous radiation treatment. And as we already discussed during our tumor board, dysphagia actually improves quite rapidly after stents, but in the long term, relief was better with brachytherapy, as you can see from your figure in the from the figure to your right, comparing the red curve that represents brachytherapy against the blue curve that compares stents. There was no difference in recurrent dysphagia, and quality of life overall favored brachytherapy. And actually, the medical costs were similar, comparing both treatment strategies, even after taking into account that 40% of patients in the brachytherapy arm had a stent at some point during their lifespan. However, there are many barriers to access intraluminal brachytherapy. As we already mentioned, there are potential complications, and that's why you need to have a dedicated intraluminal esophageal brachytherapy program with a rad-onc medical physicist and trained radiographers. It's not available worldwide, and already even in places such as the Netherlands or the UK, no more than 10% of radiation treatment facilities there have dedicated intraluminal brachytherapy programs. There's a scarcity of high quality clinical data and dose and fractionation, and we must mention that there's a lack of awareness among the medical community about the efficacy and the role of intraluminal esophageal brachytherapy. External beam radiation has as objectives both restoring the esophageal lumen, but also reducing the risk of extrinsic compression or direct invasion into the adjacent airways or vasculature. It does provide a relief in 50 to 70% of patients, and that this relief can actually last longer, 3 to 6 months. And there are no randomized controlled trials comparing against brachytherapy or stenting. We do know from population-based studies, like this one from the VA Affairs in the United States, that same as what we saw from the CIRREC trial, stents provide quite a rapid relief, but in the long term, radiation, this time in the form of external beam radiation, provides longer and better dysphagia relief. And also remember that stents are associated with complications. As I mentioned, there are no randomized trials comparing external beam radiation against brachytherapy, but the Polder study group in the Netherlands conducted a multi-center prospective cohort study comparing patients treated with external beam radiation, this time with 20 gray in 5 fractions, against those patients from the CIRREC trial who were treated with brachytherapy. And actually, as you can see, dysphagia improved more rapidly after external beam radiation than after brachytherapy. From both figures, you can see that during the first month, the majority of patients in the external beam radiotherapy group had a quicker time to first improvement and a quicker time to maximum effect. And what about combining chemotherapy with external beam radiation? We know that this paradigm is the standard of care for inoperable esophageal carcinoma, as it provides a better local control and overall survival compared with radiotherapy alone. But however, there's a potential for combination related side effects, not only from the combination itself, but also exacerbating the local effects from radiation, particularly in the form of esophagitis. And on one hand, when we're talking about definitive chemoradiation for locally advanced esophageal cancer, we do agree that we're aiming at curing, but in this patient population, we're aiming at providing relief, and we need to consider that these patients have a shorter lifespan, and the impact on the quality of remaining life can even be devastating. The TROG 0301 trial recently published in 2018 compared radiotherapy alone against the combination of chemo and external beam radiation, aiming at proving improvement in dysphagia relief, focusing on a similar population than previous trials. And the combination treatment did not provide any difference in dysphagia relief. There was a minimal improvement in dysphagia, progression-free survival, and overall survival, and with the combination treatment, but the trial was not designed to actually prove this difference, and there was an actual increased toxicity in the combination group, particularly in the form of esophagitis. So we know from this trial that a short course of palliative radiotherapy alone should be considered a safe and well-tolerated treatment of malignant dysphagia in the palliative setting. Recently published last month, the ROX trial, which was first seen at ASCO last year and now published in Lancet Gastroenterology and Hepatology, conducted in the UK, compared metal stents against metal stents and external beam radiation, aiming at improving this window of deterioration after first putting a metal stent. Again, aiming at the same treatment population, excluding patients with longer tumors, ulceration or fistula, airway involvement, or previous radiotherapy. And unfortunately, again, there was no benefit from the combination of having a stent and then having external beam radiotherapy on dysphagia recurrence at 12 weeks or overall survival. There was, however, a decrease in bleeding events in the external beam radiotherapy group, and the external beam radiotherapy arm was actually more expensive and less efficacious, meaning that one treatment modality, in this case, metal stents, was more than enough to provide palliation during the rest of this patient's lifespan. So what do I do with so many treatment modalities? My take on this is that you need to collaborate with your multidisciplinary team, with your endoscopist, med-onc, rad-onc, and surg-onc. It's fundamental to discuss each case before putting a metal stent, and not meaning that patients should not get a stent, but that you should choose wisely on which patient should have first a stent put in place, or eventually consider having first another form of treatment and then leaving stents for later if necessary. And before proceeding, we usually, as a group in our institution, ask these questions. First, life expectancy. We know that patients who have a shorter lifespan will definitely benefit from stents compared to having another form of treatment due to the quicker relief that stents provide. On the other hand, availability, as I mentioned, it would be great to have an intraluminal brachytherapy program, but it's quite scarce. Even like, for example, in our country, we do have only 2 dedicated esophageal brachytherapy programs in 15 million inhabitants with having 15 million inhabitants. So it's quite difficult to have availability for introluminal brachytherapy, but if you do have a program, you need to consider that as an option. And also the matter of sequencing. On one hand, we know that there are stents that now you can easily remove, but they are not widely available with the average partially covered metal stent. There can be issues when you need to remove them. So perhaps consider that first you can start by delivering external beam radiation, use a stent when you need it, if later, and so on. So that's why it's so important to consider sequencing and consider that more likely your patient is more likely to have more than one treatment for dysphagia during their lifespan. So in conclusion, metal stents provide a quick but short relief of malignant dysphagia. Brachytherapy delivers better relief than metal stents. Unfortunately, it's not widely available. External beam radiation is widely available, is as effective as brachytherapy in cohort studies, and there are no benefits from upfront combining any of these treatment modalities, meaning that it's better to use them sequentially if needed and base your decision in those factors that we previously mentioned. And finally, please remember that there's a need for a structured and multidisciplinary approach in patients with malignant dysphagia. As I already mentioned, it's a multidimensional experience that has a devastating impact in our patients' quality of life. There are many medical personnel involved in this patient's care, and you do need to collaborate, as I already mentioned, with your med-onc, rad-onc, endoscopist, surgeon, nutrition, etc. So with that, I'll open for discussion.
Indeed, very informative lecture, Dr. Pablo. Now I invite our discussion team, Dr. Suruchi Singh, Dr. Sridhar Sundaram, Dr. Vikas Jagtap. Kindly proceed for further discussion.
Thank you, Dr. Pablo. Am I audible?
Yes.
Yeah. So my question is, what is your take on the patients where there is a complete obstruction of the lumen, where it's difficult to even put a stent or do a brachytherapy? And these patients are not even able to fit to undergo radiation therapy, or the radiation facility is not available. So is there any other method like chemical things where any experience on that, whether the chemical ablation therapy can be helpful in these patients?
So that's a very good question. So in our institution, we usually in those kinds of cases when there's a complete like aphasia, where you don't have that, when you've basically lost any oral intake, we usually try to bypass. So meaning that we try to put an ostomy and go for ostomy and then external beam radiation, and instead of trying to move on with systemic therapy and so on. So it depends on like the degree, as you already mentioned, but in a case such as the one you were mentioning, we would try to bypass, even in the form of a gastrostomy, and then go ahead with external beam radiation.
Okay, yeah. Any change in the doses when you put stents in some patients, in these patients? Like, do you change the doses of radiation if the stent is already there? And if at all you consider addition of brachytherapy after the stenting?
Great question. So no, our practice actually is that we don't change the radiation fractionation if there's a stent or there isn't a stent, but we are very careful on any symptoms that could point out that the stent might be migrating. So we have a close collaboration with our surgeons and endoscopists. So if there's the minimum chance that this stent could be moving, we immediately remove it and go from there.
Thank
you. Dr. Pablo, hi. This is Dr. Sridhar. So I'm an endoscopist primarily. So one thing that really needs to be highlighted are the patients wherein you actually do require the SEMS. Okay, so I think from the entire discussion, we are palliating dysphagia, but there is a select group of patients who would actually require the stent. This includes patients who primarily have some form of airway involvement of adjacent structures like the aorta, or in addition, they have some fistula. So these are the patients wherein I think palliation would go directly towards putting a stent. So I think when we're actually putting a flowchart out for palliation of malignant dysphagia, I think in the very first step, you would actually look at patients who are eligible for alternative therapies like brachytherapy or for EBRT, like you said. And if they are not really eligible, I think SEMS seems like the potential option.
I would mention like absolutely, because as you already mentioned, those factors that you were mentioning are the ones who excluded patients from radiation trials, meaning that those are the patients that you would upfront go for stent, whether like not considering their lifespan or anything else, because they do have a contraindication for receiving radiation.
There is a lot of discussion on changing the dose of radiation after putting a stent. I think you've already answered that. Question largely remains, is there some difficulty in response assessment also after the stent is there in situ? Once you give radiation after a stent is in situ, is there, some difficulty in assessing response in these patients?
So it depends. We do have so after having treatment, it's usually, so there are two ways to look at this problem. One would be once these patients are treated, stents, eventually radiation. If these patients go for systemic therapy, you do need to go like to be on top of them, meaning that any symptoms could be relating to stent migration. It's difficult indeed to look at tumor response in the primary meaning.
No, yeah. So I'm not talking about stent migration. Stent migration, considering we are placing partially covered stents now, is reduced to the tune of around 7 to 8% only, even after, provided the patient receives some form of therapy. Now, in patients who do not receive any therapy, the stents usually do not migrate. We do not see stent migrations. So I'm talking about response for the primary after, once we have the stent in situ, is there some difficulty in assessing the response once you give radiation?
Yes, indeed. So from the primary tumor, yes, there could be some difficulties as if you're looking at the CT and having the stent and so on. Yes, that could be an issue. Whether our patients are treated on trial or off trial, patients treated on trial make it difficult to assess the primary tumor and conduct like a conventional response assessment. And on the other hand, on patients treated off trial, yes, indeed, it does make it difficult, but you are kind of basing a tumor response not only on imaging, but also on the clinic. So on clinical symptoms, meaning that in the long run, you kind of run into this thing where you don't know if your patient is progressing or not, unless there's like overt symptoms or eventually like having distant progression.
Yeah.
Good evening, Dr. Pablo. It was an excellent lecture. You almost covered all the points. I just had one or two clinical scenarios which can also be in continuation with Dr. Sridhar's comment. One was, do we change the palliative technique, the palliative options, depending on the morphology of the tumor, whether it is a stricturous growth or it is a proliferative growth, which we know will definitely respond to RT, and the stricturous growth will not respond that much to RT. So do we change palliative options depending on the type of growth?
Good question. No, so far, I haven't done it in my practice, and I'm not aware of any guideline or expert recommendation that actually encourages you to do that. But I do agree that definitely that gives you an insight that you might need another treatment relatively soon, meaning that there might be a chance that you should consider a stent, for example, instead of like when you usually say, yes, you will catch that maximum relief quite quick with external beam radiation, for example. You might need to consider that at 1 month, you perhaps won't have that maximum dysphagia relief that you were expecting or that you expect in most patients. But wouldn't consider at this time having a major change in treatment planning or according to morphology.
And a very similar scenario when we try to palliate a patient who has already been irradiated and has a local recurrence of the disease. Do we actually think about going to stent directly rather than taking him for re-radiation? Are these patients to be upfront taken in or to be considered for stents?
Great question. Would consider re-radiation only if there's a contraindication for a stent. Like stents are the main solution for dysphagia palliation after having external beam radiation.
Thank you so much.
Thank you, Dr. Pablo, for a very informative and excellent lecture. Thank you so much. Hope lots of the queries has been answered, which arose from the previous discussion. Thank you, Dr. Pablo, and thank you, discussion team. Thank you. Now, for the further conduction of the session, I would like to invite my co-chairperson, Dr. Sonali Pingle. Dr. Sonali, it is over to you.
Yeah, good evening, everybody. I would like to invite Dr. Srinivas Chilkuri for the next talk. He'll be giving his insights into re-radiation in esophageal cancers. And he is a senior consultant in the Apollo Proton Center at Chennai. Over to you, Srinivas.
Thank you, Dr. Sonali, and thank you, organizers, for giving me this opportunity to talk on a rather challenging subject. And then the topic chosen also is very interesting, exploring the limits of radiation in esophageal cancers, and especially in the context of re-radiation to esophagus. And I imagine that this is challenging because most of the data which I will be presenting or showing is retrospective, small, even I would call some of the data anecdotal. So most of it is not really robust evidence as far as any particular treatments are concerned. So there is a lot of subjectivity. There's a lot of judgment, a lot of it's like palliation. It needs to be extremely individualized. So in re-radiation setting, unlike in head and neck cancers and others where it is very, very clear cut, in esophageal cancers it's a bit more tricky than in many other sites. I would like to thank my colleague Dr. Sham for helping me make this presentation. If I have to understand, if I have to tell you the context of re-radiation to esophagus, not just esophageal cancers, I mean, you could have three different settings. One could be recurrent esophageal, loco-regional recurrent esophageal cancers. After a particular interval, the cancer is recurred and you would like to treat it again. Or you would like to re-radiate to esophagus after incidental radiation to esophagus because of you have treated previously a mediastinal primary. It could be a lymphoma, thymoma, chest wall, breast, or it could be re-radiation for persistent disease, which is not a very likely scenario. I agree that I mean, there are a few, very few select studies which have used ILRT after external beam radiation therapy for persistent disease. So except for that, I think mainly I would like to focus on the top two indications. We all know about the toxicity after initial radiation itself. So there are a set of esophageal toxicities. You could have lung toxicities. You could have cardiac toxicities, both acute and late. And normally we kind of ignore and push it down the cardiac toxicity specifically. And we all need to be aware that there is a significant chunk of patients, especially those who tend to survive for longer periods. They tend to have cardiac events, grade 3 cardiac events, which probably require some intervention and treatment. So, this is the background. I know most of the patients who tend to have a recurrence after, say, a significant period of time would have had some of these toxicities, and that also needs to be borne in mind before you intend to treat these patients in a radical fashion. So when a patient of such a patient with loco-regionally recurrent esophageal cancers, or a patient who requires irradiation to esophagus because of previous incidental radiation, the key questions which need to be asked are, especially in the context of loco-regionally recurrent esophageal cancers, are we radiating for the right reasons? That are we expecting the responses? Is it increasing the dysphagia? Is it improving the survival? and what could be the concerns we should be worried about, and what are the concerns related specifically in terms of toxicity. Who are the patients who would really benefit with radical intent radiation? What dose would be optimal? We've heard about a lot about dose escalation. So let us see what is the evidence in the re-radiation setting. What modalities could one choose between photons, brachytherapy, or protons? So as I mentioned, there are a lot of small retrospective studies. I would like to start with one of the Japanese studies, 31 patients. Most of the data which I'm going to show you today are squamous cell carcinoma, esophageal cancers, specifically related to thoracic radiation. Initial radiation dose was 60 gray, re-radiation dose median was about 40 gray, ranging from 36 to 60 gray. The authors had divided the group of patients who have been treated into curative and palliative group, and irrespective of whether they divided into palliative and curative and the doses, most of the patients completed the planned dose of radiation, and nearly 3/4 of patients showed objective response. And I'm sure palliative chemotherapy also, one would be very happy to have to offer a palliative chemotherapy for such patients who would have a 75% objective response rates. So I think radiation is up there with respect to palliative chemotherapy, at least for in terms of when you're talking about palliation in these patients. Similarly, a lot of these patients, if the symptoms, dysphagia is primarily due to esophageal tumor obstructing, not just the previous sequelae of radiation, they tend to benefit with radiation in terms of dysphagia relief as well in close to 60% of patients, as shown by this study. Initial RT dose of 50 gray, median time to recurrence of about 2 years. Re-radiation median dose was about, again, close to 60 gray. And you see that the dysphagia relief was achieved in a large majority of patients. Similarly, again, another study of 87 patients, esophageal squamous cell carcinoma, patients who received re-radiation versus those who did not receive. Among those who received, you clearly see that there is a slight benefit in terms of even overall survival. Of course, retrospective studies with all their limitations can show varying things, but the fact is that patients who receive radiation in a recurrent setting tend to do slightly better. And you can see that even the impact of chemotherapy concurrently given with re-radiation, this particular study did not show much improvement as far as the overall survival was concerned. I searched quite a bit for some Indian studies to show, but I could find this very interesting study, which was a comparative evaluation between re-radiation and demand endoscopic dilatation versus only endoscopic dilatations in patients who had recurrent residual infield esophageal malignancies, about 35 in each group in the re-radiation as well as dilatation. And what they found was, what they did was, if the disease-free interval was less than a year, they irradiated to less than 50 gray, between 45 and 50 gray, 1 to 1.5 years, 50 to 55, and more than 1.5, 55 to 60 gray. So very close to the doses which in the primary setting, what they have used. They've used if the disease-free interval was beyond 1.5 years. And what they found was the patients who received re-radiation had better dysphagia-free survival. And what they mentioned is quality of life. And I would say that symptom profile was at least better in those patients who received re-radiation compared to those who received endoscopic dilatation alone. So why radiate? If at least the retrospective studies show that survival could be better in patients who receive re-radiation to the local site. So irrespective of the setting, whether it's palliative or radical, there could be some benefit in terms of reasonable response rates and symptom relief. So irrespective of whether the intent is radical or palliative, they tend to benefit from re-radiation. Of course, there are toxicity concerns. A lot of studies have shown a significant burden of toxicities in these patients. Nearly 1/4 of them had, in this study, had grade 3, grade 4 perforation or hemorrhage in esophagus. And 4 out of these 7 toxicities in these 37 patients had a re-radiation after interval of less than 12 months. So within 1 year, irradiation is always a bit tricky and challenging in these patients. They tend to have high grade of toxicity. You can see that in these patients who had long-term survivors, those who had grade 3 or more toxicities, most of these toxicities happened when the irradiation happened within 12 months. And of course, there were a few patients who had grade 4, grade 5 toxicities as well in patients who had these particular re-radiations. The toxicity, if you see slightly larger, it's very heavily coated paper in the re-radiation scenario. They noted about 10% rates of tracheoesophageal fistulas, 15% pericardial effusions, grade 3 pneumonitis in 25%, all symptomatic grade 3 pneumonitis noted in these patients. And compare that with those patients who have not received re-radiation. So re-radiation is definitely considered to be toxic in majority of patients, at least in those patients who have a disease-free interval less than 12 months. Again, a small study also showed that 33% had significant toxicity, tracheoesophageal fistula. And again, all these three patients had a re-RT interval less than 12 months. So the toxicity concerns are definitely there, and hence the patient selection is important. 25 to 35% esophageal toxicities are well documented. There are studies which have shown ranging from 10 to 25% radiation pneumonitis and 15 to 20% cardiac toxicity, especially pericardial effusions and cardiac arrhythmias and myocardial infarctions have been noted with a median follow-up of less than 1.5 years. So these typically happen within 1.5 years. So these needs to be, these need to be concerned, especially if we are expecting a radical, if we are hoping for a radical treatments. Interval to re-RT is important. At least more than 12 months is what is preferred. As I said, since the toxicity is very high, the patient selection is of paramount importance. Again, in the Japanese study, which I already showed, the authors divided the curative and palliative intent based on the dysphagia score, the presence or absence of distant metastasis, and performance score. 0 to 2 patients were considered curative. All other patients who either had distant metastasis or had as poor dysphagia scores or have poor general condition were considered palliative. And you could clearly see that they could differentiate in terms of outcomes. The curative patients did slightly better than patients who underwent palliative treatment alone. So possibly patients who have an early recurrent disease, short segment disease, patients with good performance status, a reasonable interval between initial and re-RT, at least more than 12 months, are possible candidates for considering radical intent treatments. What dose would be a right choice? The optimal dose is extremely controversial. Various groups have used various doses in radical setting. In this particular study, you can see that different set of patients, about 47 patients. Initial RT dose was 50 gray. The median time to recurrence was 26 months, which is about 2.5 years, which is not bad. Re-radiation median dose, again, 58 gray. And this was, most of them were squamous cell carcinomas. 37% of them had local and 10% had 78% had local recurrence only, and some had local and nodal failures as well. And as 1/4 of patients also received concurrent chemoradiation in these set of patients. Patients with time to recurrence more than 2 years had a better overall survival in this study. Patient with local only recurrence versus those who had no local and nodal recurrence had a better overall survival. And those patients who received more than or equivalent to 50 gray had slightly better outcomes compared to those who received less than 50 gray. This is probably the largest retrospective data which I have encountered of about 252 patients. Most of them had upper thoracic or in the middle and lower thoracic tumors. All of them were squamous cell carcinomas. Radiation dose initial was a radiation dose at the time of recurrence was more than 15, a majority of the patients. And initial treatment consisted of chemoradiation or even surgery followed by adjuvant chemoradiation was a majority of the patients. And what they found was that the relapse-free interval was a significant factor which determined the outcomes. The concurrent chemotherapy, the esophageal stenosis at the time of recurrence was also a significant predictive factor. So the authors also noted toxicity of 20% esophageal perforation. Radiation pneumonitis was noted in about 10%. Esophageal hemorrhage was also seen in 11%. So it's a reasonably large burden of toxicities. But the authors concluded that lymph node recurrence alone, isolated lymph node recurrence, as we have shown, as we have seen previously as well in other talks, isolated local recurrence tend to have slightly better outcomes compared to those who have a local failure as well. Patients with relapse-free interval more than 12 months had better outcomes. The outcomes was better with patients receiving more than 50 gray. In this study particularly, BED was more than 131.5. But 50 gray is probably a cutoff. But 131.5 would be equivalent to 60 gray in the beginning, 60 gray BED and 60 gray BED again. So 120 gray BED would be a most common schedule, 50.4. But they did not show any difference in terms of the dose between 31.5 versus less and more. Patients received re-radiation combined with chemotherapy had a better outcome. Those who had esophageal stenosis had a worse outcomes in these patients. Decision regarding dose is extremely challenging, and I just want to emphasize that we don't see just the esophageal and the lung and the heart doses. We also need to concentrate a little bit on tolerance to brachial plexus, great vessels as well. Sometimes these are a bit of a concern, and tolerance to these structures need to be considered when we are considering the re-radiation doses. So what dose? At least 50 gray and 12-month interval at least, local only recurrence better, or lymph node only recurrence definitely better compared to lymph nodal plus local recurrence. What modality? Brachytherapy. Again, this is an Indian study from the Tata Memorial. Dr. Vinay Sharma's one of the old studies showed that, again, brachytherapy had a significant chunk of patients who benefit in recurrent setting, but for the patient selection is important. We know the selection criteria for brachytherapy in esophageal cancers. There are contraindications. There are certain poor candidates as well, and which need to be considered when considering brachytherapy. Re-radiation in proton therapy is also an exciting, definitely a possibility. As we've seen from the previous speakers, that there is some evidence now for proton therapy in upfront esophageal cancer and reducing acute toxicity in both definitive and preoperative setting, which is being now under a phase 3 randomized trial. But personally, we have treated a few patients, 4 patients treated so far. Median age was 75 years. Median length of involvement was about 7 centimeters. All had a DFI more than 3 years. 3 of them were esophageal primaries. 1 patient was of mediastinal neck. In fact, had an NHL thyroid as well as breast cancer a few years back. All patients received 50.4 gray with concurrent chemoradiation, and 3 patients remain locally disease-free at last follow-up. 1 patient had a local recurrence already. So this is what our initial experience has been with re-radiation with proton beam therapy. So to conclude, re-radiation is extremely challenging but gratifying in very select group of patients for local regional recurrent esophageal cancers. It leads to symptom relief, it leads to dysphagia relief, but there needs to be a extremely careful patient selection, a good performance status, longer DFI. Those without esophageal stenosis would be probably appropriate candidates for radical intent. At least 50 gray without concurrent chemotherapy is preferred. There are a large burden of toxicities which need to be kept in mind, with about 10% grade 5 toxicities as well reported across many studies. 25% esophageal stricture, perforation, hemorrhage, even radiation pneumonitis, symptomatic radiation pneumonitis in about 10%. Conformal techniques of radiation in suitable patients is the key in suitable patients. Thank you.
Thank you, Srinivas. Excellent talk as usual and very precise. I would now like to call for discussion Dr. Geethi. She is an associate professor in the Department of Radiation Oncology at RCC, Thiruvananthapuram. Dr. Swapna, she is a senior consultant and head Department of Radiation Oncology at Hyderabad. And Dr. Aditi Agarwal, she is a senior consultant in the Department of Radiation Oncology, Paras Hospital, Gurgaon.
Yeah, good evening all, and thank you for the opportunity given for me. Actually, it's a very well covered topic, and most of the studies in this, as Dr. Srinivas has mentioned, is retrospective. So my question with Dr. Srinivas is there any role for SBRT in the case of free radiation?
SBRT re-radiation, I would probably look at patients who have had non-esophageal lesions, could be an isolated lymph node, or in previous case, we've read about adrenal or a bone met or a brain met. I don't see SBRT to the primary esophagus is of any role as of now.
Is there any role in isolated nodal recurrence?
Yes, that's what I said. Isolated nodal recurrence could be one of the potential situations where SBRT could be considered. There is data, at least, to say that isolated locoregional lymph nodal recurrence, especially not included in the previous nodal radiation, especially in the setting of preoperative chemoradiation with a dose, 41.4 to 45 gray, there is certainly a role for re-radiating those nodes, and there is data to say that these patients do slightly better than those who have local recurrence.
Thank you, doctor. Thank you.
Hello, good evening, sir. Is there any difference? Because in the previous talks, there was a discussion about the dose escalation in the primary radiation. So the patients who has received more than 50 gray in the initial radiation, and what could be the re-irradiation dose? Is there any difference depending upon the gap, less than 1 year, and more than 1 year? What should be the cumulative dose we have to consider for the re-irradiation?
So good question. As I said, the choosing optimal doses is definitely a challenge in many situations, many clinical situations. The radiation dose, if the disease-free interval is fairly long, I would like to go to the radical doses, which we normally offer to the patients. So since in the upfront setting, there is very little evidence for dose escalation beyond 50.4 gray, I would be really hesitant to go beyond 50.4 in recurrent setting as well. As I showed you, there is a large burden of toxicities, both esophageal, cardiac, and pulmonary toxicities. And I would not feel that we are doing justice by escalating doses beyond 50.4 gray, especially in the context of concurrent chemoradiation. I would not be very happy to escalate doses beyond 50.4 gray. As I said, even 50.4 gray would become difficult in cases where initially patients have been treated with 60, 63 gray, and there is significant, there is significant esophageal stenosis. In fact, in some patients, in one of the studies which I have shown, if there is the tissue planes between the re-radiated esophagus and the adjacent tissues is lost completely, they have a very high propensity for esophageal perforations. And those are probably not suitable for re-radiation. And even if they are being re-radiated, I would not be going beyond 50 gray.
Thank
I think Dr. Aditi, are you there? Actually, her message is here. She is not able to connect because of poor connection. We can proceed.
V20 for the lungs dose limit for the irradiation.
Yeah, Sayan, you can take it forward.
Yeah, so I think because we are running late, we can go to the mm, next session. That is like Dr. Naveen, who will be presenting the survey results, that the survey that we have done with our registration form. So I request Dr. Naveen to present the survey results.
And today, by the way, I'll tell you, Naveen has done a fantastic job and answering to all the questions asked to the experts. Naveen was very prompt in answering all the questions. So, thanks, Naveen, to answer all the questions.
Yes, thanks a lot.
Yeah.
Yeah, thank you so much. But I believe I'm not presenting the uh, survey results, but rather I'm summarizing
Yeah,
the
you're
questions.
summarizing. Yeah,
Isn't
so
that
you are
right?
summarizing, and Dr. Shagun or Dr. Divya would
Yeah.
give the results, but you are
All
summarizing
right. Okay.
today.
Yes,
Yeah.
yes.
Great.
Sorry for
Fine.
that.
Okay. All right. So in the next under 10 minutes, I will try my best to summarize three excellent sessions that we had today evening. So the first one was by Professor Edgar Ben Joseph. He spoke on dose escalation in CA surveys, which is quite a controversial topic, and he also touched upon the benefits of protons. So we know that the toxicity in radiating esophagus patients, the most important thing, as he mentioned, as we have learned from radiating lung cancer, is the toxicity, the long-term toxicity because of radiating the lungs and the hearts. The acute toxicity is mostly because of the mucosal irradiation of the esophagus, but we need to be wary about the lung doses and the heart doses, and we have learned our lessons from NCRC. Protons, by their inherent physical advantage, they reduce the toxicity, the acute and the chronic, and they have potential to reduce post-operative complications, especially when we use them in neoadjuvant setup. They also have been shown to reduce the hospitalized lens post esophagectomies. Interestingly, it has been shown that by radiating lesser amount of mediastinal pool, the grade 4 lymphopenia rates are also lesser with protons, and this has got great implication on patients' overall survival, as again data from lung cancer has shown. And this picture kind of summarizes the entire thing for us, where it's so starkly you could see the difference between 3D-CRT, IMRT, and the advantage with protons. But the problem is all this is fine, but we do not have any randomized data. So when Lin et al. Published their phase 2B trial last year, we were quite excited, and they used a very unique endpoint, a composite endpoint of using total toxicity burden, and they showed that with protons, the post-operative complications, almost all the post-operative complications were lesser. But the problem with this is, as Dr. Srinivas was mentioning, the techniques that were used are quite primitive, if I can use that word. Passive scattering was used. IMPT, we know, has better dosimetric advantage over passive scattering, and also probably there was a learning curve here because 2012 to 2019 is when they accrued patients in this trial. So we know, again, similar to the NSCLC story, probably when we use IMPT, the data might favor proton more. So to test this, the NRG-GI006 trial is ongoing, where they're comparing protons versus IMRT in preoperative setup, and we will know this for sure in a couple of years where we stand. Dose escalation is extremely controversial. I would say that we are split mid, because there are few who believe in dose escalation and we would swear by it, and then there are those who do not. So the Western world believes that a dose escalation has not helped. Like this large NCDB data base showed that dose more than 60 gray was no better than 50 gray. But when we look at data from the Asian population, this study, a large retrospective study again from Taiwan, over 2,000 patients, they showed that a higher dose, especially when you use IMRT, and all of them were squamous cell carcinoma, there was a benefit. We published our own data. Close to 300 patients, again retrospective data, we showed that more than 63 grade patients actually did better than those lesser. So we were hoping that although the intergroup 1, 2, 3 was kind of an archaic old study, the newer generation studies would lend us support to the concept of dose escalation. But however, the ASCO 2018, when the Chinese trial was presented, still it is only presented as an abstract. We don't know the entire paper, but this is a negative study. Their primary endpoint was LRPFS, and that was negative. Similarly, the Art Deco, which was published earlier last 2020, that is again a similar concept of 50 versus 60 gray. That did not show any benefit. So both for adenocarcinomas and squamous cell carcinoma, the future slightly looks bleak. But I hope protons might change that. Although Dr. Edgar Ben Joseph in his talk said that he is still skeptical about the entire thing, but we need to look at the data before we decide for ourselves. Protons definitely dosimetrically are superior to IMRT, and probably in preoperative patients, we would have an advantage of protons, like the ongoing phase 3 trial would show in a couple of years. He also introduced a very controversial topic, saying probably early stage may benefit better than late stage because they are all failing distally, so no point in chasing them with dose escalation. So let's hope in the next few years we will have more data to end this controversy. So Dr. Pablo spoken on a very unlikely and not often spoken about topic of palliation of dysphagia, especially in metastatic settings. We know that most patients end up having dysphagia either because of the disease itself or nodal disease or because of our treatment. There are multiple options: surgery, stenting, thermal ablation, photodynamic therapies, and radiation. There are many trials which have been conducted, many small single institutional retrospective studies, but I would like to show that the IAEA had done a couple of series of trials in, which I'm proud to say that Tata Hospital was part of it. So what they showed was that when you use ILRT in combination with external beam radiation, either before or after, there was definitely an advantage. Patients' dysphagia scores were better. But we also know that when you use concurrent chemotherapy along with either be it brachytherapy or external beam radiation and brachytherapy boost, the outcomes are worse because patients tend to have a lot of toxicity. This study, which Dr. Pablo again alluded to, says that with stenting, the response, the dysphagia relief is more immediate, but it's not in the longer run. Probably brachytherapy or external beam radiation scores over stenting. This is another study which looked at multiple different interventions, be it photon dynamic therapy or thermal ablation, and they showed the best results were always when you use external beam radiation as part of your treatment regime. Also, compared to all the different regimes that you have for palliation of brachytherapy, palliation of dysphagia, brachytherapy is the most cost-effective modality. So all the more reason that we should use. So the takeaway message from his talk was that you should always collaborate with your colleagues, discuss in an MDT, and make the best choice for the patient. Always consider radiation, be it ILRT or external beam radiation or in combination, and we know that they are definitely cost-effective. Dr. Srinivas also spoke about, again, a very rare topic, re-radiation in CA esophagus. We know that RIAT has shown a lot of promise in lung cancer, head and neck cancer, and brain tumors, and even in rectal cancer. But esophagus, traditionally, the barrier has been that the perceived toxicity, the high incidence of toxicity because of mucosal radiation. But he also showed with a lot of data, most of them are retrospective, but that is the best that we have, that re-radiation definitely provides dysphagia relief, probably some survival benefit, but again, you should take that with a pinch of salt because these are retrospective studies. The most important thing is that you need to select your patients right. So patients who have long disease-free interval or patients who have short segment disease. And if you use modern techniques, you would have optimal outcomes. The right dose to use is again unknown, but probably 50 gray should be a starting point, and probably concurrent chemotherapy might not help. So thank you very much for your attention. I would now hand it back to the chairperson to take it forward. Thank you very much.
Good evening, everyone. As the session comes to the end, I thank all the eminent speakers for the wonderful talk. I think all the issues pertaining to the management of CA esophagus have been addressed adequately. And despite being on a virtual platform, the lectures and the discussions were conducted very smoothly. So I conclude by congratulating all the organizers and convey my best wishes for all their future endeavors. Over to Dr. Sonali. Dr. Sonali?
Hi.
आप introduce कर दीजिए you.
Hello. Hi. Good evening. Could you hear me?
Yeah, so we can go to Dr. Sonali, please. Dr. Sonali, please.
Is Dr. Sonali there?
Yeah, she's
Yeah,
there.
I'm there.
Yeah, please. You can go ahead, Dr. Sonali.
Okay. Yeah, I could. Can I invite Dr. Shagun Mishra? She is going to be presenting the results of the survey that has been taken.
So thank you again for the invitation, and we are moving towards the end of the conference. Very excellent discussions from both national and international faculty. So we move on to the survey, and I'll just repeat the preamble again today for those experts who had not joined yesterday. So when we set out to conduct this conference, we also wanted to look into the variability in practice in the Indian setting, and we set out a survey which was mandated at the time of registrations. And the broad outline of the survey was we had general questions looking into aspects like what's the setup you have, do you have a dedicated GI surgeon at your center, etc. And there were case vignettes, and these case vignettes were discussed by the panelists and also discussed by the experts and summarized. So without wasting much time, I'll just move on to the survey results. So when we look at the region-wise registrations as to from where did the people participate, and we had a good representation from North and South India. We didn't have a very good representation from West or Eastern India. And let me again take you through the epidemiology of esophageal cancers in India. It is the 8th most common cancer. We see about the prevalence is about, the incident cases are about 37,000 cases in a year, and about 42,000 prevalent cases. The incidence, age-adjusted incidence is about 3.9%, and it is one of the most common cancer in some of the northeastern states of a country. So that's the epidemiology. General questions, and the first question we asked as to what is the nature of organization that you work in, and the majority of them actually work in the public or charitable trust, and whether the participants do they have a teaching program in form of a formal MD or DNB. 2/3 of them responded yes. What we asked as to whether they practice radiotherapy in esophageal cancers, and the majority of them, 90%, said yes. Whether they have a dedicated GI surgeon, 2/3 of them again said yes. We asked about whether they have a multidisciplinary clinic or a team, and about 80% of them said yes to this question, and 40% of them said that they had a dedicated GI MDT, but about the same number said that they have a MDT, but which is not site specific. We further wanted to look into what is this MDT type that they are talking about, and 50% of them said that the type of MDT they have is wherein the patients are routed into the clinic before treatment, before starting any treatment. About 34% said that they are rooted in the MDT on as required basis. And 6% said that the MDT is basically after surgery. About 9% answered that they have no MDT. And this slide, again, I mean, this came as a surprise to me as to what are the equipments they have in their center, and they could choose on multiple options. And about 2/3 of them do have linear accelerators. Remember, I told you earlier about 2/3 of them are responding from public sector hospitals, and the majority do have linear accelerator. An interesting point, Pablo was mentioning about the availability of intraluminal brachytherapy, and about 50% of the respondents did say yes, they do have ILBT at the centers. We also asked as to the number of
Dr.
Some
Shagun,
issue
we
with
could
Dr.
not
Shagun?
hear you.
We are not able to hear you, Dr. Shagun. Some issue with your network.
it was just invading the muscularis.
So yeah, you're back. Dr. Shagun.
Dr. Shagun, unmute yourself.
Yeah, Dr. Shagun, please unmute yourself. So we lost you for a while.
Yeah.
You are back now.
Okay.
So
maybe can you hear me now?
Yeah, maybe you can go a slide back. You can go a slide back. Yeah.
Is it this?
Yeah, this one. Yes. Now you can start.
So we asked as to the number of cases of esophageal cancer that they treat in a month, and slightly over half of the respondents said that they treat about 6 or more than 6 cases of esophageal cancer, which is a pretty good number. So this is the first case, and I think Kinjal, you presented this case, a 75-year-old gentleman with metachromatous primary of the lower esophagus, T2, T3 disease, and a very good performance status with no adjacent lymph node involvement, minimal comorbidities, I would say, and what should be the line of treatment? And the options were as follows: upfront surgery, neoadjuvant radiotherapy followed by surgery, radical radiotherapy with single agent cisplatin, and the dose of radiation was 50.4 gray, radical radiotherapy 50.4 gray with a dual agent, radical radiotherapy alone, but escalated to 54 grays, and palliative RT. So basically, the respondents had to rank each of these options. And so there was a ranking priority for each of these options. Rank 1 is basically the highest priority that they give to the option, and rank 6 is the lowest priority. So let's see, what do the respondents say? And as you can see here, for upfront surgery, there's a trend that the respondents considered it low on priority. Only about a fourth of the respondents would consider it to be as their number 1 option. And the majority of these respondents, when I looked into the data, they either do not have a MDT, or they discuss the patients post-operatively, or they are discussed on as and required basis. So I would say, I mean, there wasn't a proper MDT in place, but certainly the ranking priority was lower for this option. The second option was neoadjuvant CRT followed by surgery, and you can clearly see a trend over there, about a third, and there was inclination for most of the participants to choose this as an option. And when you consider rank 1 and 2, about nearly half would choose this as their option. Considering radical radiotherapy with single agent cisplatin, and again, I don't see a real trend over there, but again, less than half would consider this as an option, and there is an inclination towards considering this as one of the priorities. The fourth option was with a 2-drug regimen, and I could not see any clear trends over there. About a fourth would consider this as one of their priority options. Dose escalation, again, no trend, and only again a fourth would consider this to be as one of the priority options. Palliative radiotherapy, and most of the respondents, there was a clear trend, and everybody would rank it very low in their priority. So these options are now ranked according to the highest priority that people gave. We saw that NACRT followed by surgery was considered to be the most chosen option, followed by radical radiotherapy and cisplatin, and then the other 4 options followed. But as we went through the discussions, I felt that it was not only NACRT followed by surgery, but radical radiotherapy with a dual agent is something which was recommended by the panelists and the experts. So coming to the second question, I think this was presented by Rashi, a 60-year-old gentleman treated earlier with radiotherapy and now has a nodal recurrence and a disease in the G junction, and a relatively good DFI of 2 years, and has been tried on multiple lines of chemotherapy, still continues to progress. So what are the next options? This was the question asked, and these were the options that were listed. The ranking priority, as I mentioned earlier, rank 1 is highest, 4 was lowest. So, and each of these options had to be ranked. So let's come at the first option, that is the next line palliative chemotherapy. Again, there is actually no trend, but still a lot of them would consider this as their priority. For best supportive care, again, no trend, but more inclination towards considering this as their priority. Re-irradiation with conventional fractionation was ranked low on priority, and you can see that there is a trend over there. And a re-irradiation with SBRT, again, there is absolutely no trend. But I just looked into as to who are considering this as as their priority, number 1 or 2, and 50% of them said that they would consider SBRT, and most of them would have a multi-lean energy LINAC or advanced kind of equipments like tomotherapy or CyberKnife. So again, when I rank them according to the priority that people have given, re-irradiation with SBRT was scored highest, but actually there was no difference between the next line palliative chemotherapy and SBRT, minor differences, followed by best supportive care and re-irradiation with conventional fractionation. And as we heard from the last expert, that yes, conventional fractionation could be one of the options and can be tried in patients who have a good performance status, a longer DFI, and does not have a stricturous lesion. So that was the consensus that I could make out from the experts. So the last question again was an 82-year-old gentleman and has an oligometastatic disease, has marked luminal narrowing and a good performance status. So these were the treatment options that were listed. And let's see as to how people have ranked. Brachytherapy, interestingly, very few of them ranked this as their priority, despite majority of the centers having ILRT in their center. And there is no trend there. Best supportive care, again, no trend there. Stenting was ranked high. About a third would consider stenting as their priority number 1. Palliative EBRT, I mean, Interestingly, with conventional fractionation, there was no trend palliative EBRT with hypofractionation, which I thought should have been priority 1 by most of them. Again, there was some trend toward some inclination towards ranking this as option 1. Palliative chemotherapy, again, there was a low ranking priority. So when I listed them again in order of priority, so stenting was considered as option 1 by most of the respondents. Palliative EBRT by hypofractionation was considered as the highest priority by about a fourth of the respondents. And we heard from Dr. Pablo that stenting as palliation for dysphagia provides immediate relief, but has a shorter duration of dysphagia relief as compared to ILRT, and EBRT with hypofractionation is also a very viable option. So with that, I would like to end the survey and the results. And this is the team of oncologists who sat down and brainstormed to actually, design the survey, which is based on real case scenarios. Thank you very much.
Thank you, Dr. Shagun. So good evening all. So this grand conference comes to an end, and it's my privilege to have been asked to propose a vote of thanks on this occasion. And it has been a fantastic conference, as you all will agree. And first of all, on behalf of Indian Cancer Congress 2021, Chapter 1 on stomach and esophagus, I want to extend a very hearty vote of thanks to all our esteemed faculties. We had 75 national faculties and 4 esteemed international faculties. And a sincere thanks to all the delegates who have registered and joined for this conference. We had around 500 registrations, and the people joined even on a Saturday till late evening. People are there and just listening to the talks. So thank you all. And I want to thank Dr. Vinita Goel for giving us scientific support, for guiding us for this, the scientific, the topics and other scientific issues. And a very hearty thanks to Dr. Santam Chakraborty, who has been instrumental to design the survey and who is guiding us constantly throughout throughout the process of organizing this conference. And my sincere thanks to Mighty Duo. They have managed the conference very, very well. Special thanks to Mr. Ravindra Purohit and Ms. Sunidhi for managing the conference so well. And my sincere thanks to Max Healthcare for sponsoring the conference. And last but not the least, a sincere thanks to the entire organizing team, and especially Dr. Rashi Agarwal, who had conceived this idea, and all other team members who have worked very, very hard to make it possible. We had meetings almost on every day, and many of us sacrificed their anniversaries, their birthdays, and they continued working to make this grand conference a success. So special thanks to all the team members. So thank you very much for joining us, and we look forward to do more and more conference on especially GI oncology. Our next conference is planned, which will be a physical conference, not a virtual conference, and that will cover almost all other topics that we have not covered in this conference, all other sites. So I welcome you all for our future conferences as well. We'll be having this program regularly. Thank you all. Thank you very much.
So Sayan, I'll interrupt you here that, you have invited everybody. So we need to say that, this was the chapter 1, esophagus and stomach.